हेलो हेलो
हेलो हेलो हाँ बराबर છે
हेलो हेलो चेक
तो चेक भी ऐसे होगी चेक
माइक चेक हेलो हेलो चेक हेलो हेलो પેલા લોકોનું બતાવો થોડું પેલું વિડીયો ચાલુ કર દો हेलो 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 माइक टेस्टिंग
Discover
हेलो चेक हेलो हेलो
Gujarat, where ancient healing traditions meet modern medical excellence.
हेलो 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 हेलो
Discover Gujarat, where ancient healing traditions meet modern medical excellence. Offering world-class healthcare infused with timeless wisdom, Gujarat is a destination for rejuvenation. Explore iconic landmarks like the Statue of Unity and Asiatic lions while experiencing healing with heritage. Embracing the theme Vasudhaiva Kutumbakam, One Earth, One Family, One Future. The Department of Health and Family Welfare, Gujarat, provides comprehensive healthcare at Medicity, Ahmedabad, featuring the Gujarat Cancer and Research Center, Institute of Kidney Disease and Research Center, offering treatments for all ages, including pediatrics. The UN Mehta Institute of Cardiology and Research Center, established in 1982, has grown into India's largest super specialty cardiac hospital, offering world-class care. Guided by the visionary leadership of the Honorable Prime Minister, Shri Narendra Modi, the institution's excellent performance and health services are supported by the Honorable Chief Minister of Gujarat and the Health Minister of Gujarat. Guidance is also provided by the Principal Secretary of the Health Department of the Gujarat Government, the Chairman of the institution, and the Health Commissioner. Your heart, our priority. UN Mehta Heart Institute offers world-class cardiac care with innovative treatments, state-of-the-art facilities, and compassionate service. Committed to holistic recovery, we prioritize restoring your heart health and improving your quality of life. Why choose us? Our world-class cardiologists, cutting-edge technology, advanced diagnostics, and state-of-the-art facilities ensure top-notch care. We provide personalized treatment, multilingual support, and affordable excellence, delivering high-quality cardiac care at a fraction of global costs with compassion and dedication to patient well-being. We provide comprehensive cardiology services with advanced diagnostics, including 3D, 4D echocardiography, hybrid cath labs, digital subtraction angiography, 3 Tesla cardiac MRI, high-resolution CT angiography, Holter monitoring, and stress testing, ensuring precise, patient-focused care for all ages. We provide angioplasty, stent placement, rota, intravascular ultrasound, valvuloplasty, and transcatheter aortic valve replacement (TAVR) for advanced care. Our cardiac surgery services include heart and lung transplants, CABG, beating heart, robotic, minimal access, heart valve repair replacement, and congenital defect repairs, including complex neonatal procedures, ensuring precision, rapid recovery, and exceptional outcomes. We treat life-threatening rhythm disturbances with 3D mapping, radiofrequency ablation, and pacemaker defibrillator implantation, including cardiac resynchronization therapy with a defibrillator, CRTD, and automatic implantable cardioverter defibrillator, AICD. Our outdoor patients admit more than 165 individuals, perform over 97 cardiac procedures, and conduct more than 27 open heart surgeries. With over 34 lakh OPD patients, 5 lakh admissions, out of which 3,28,000 have undergone heart procedures and 91,000 surgeries performed. Our internationally trained team uses the latest technology for exceptional care. More than 400 surgeons from across the nation and 14 overseas countries have completed observerships program. The Center of Excellence, Complex Aortic Surgeries. Collaborative teamwork and continuous training enhance results. Our state-of-the-art facilities include 15 advanced modular operation rooms, 6 cath labs, 1251 cardiac beds, supported by the largest paperless ICU system and robotic-assisted surgery for precision. For international patients, we provide seamless care with travel assistance, accommodation in comfortable hospital suites, multilingual support, and 24/7 patient concierge services. Our partnerships with nearby hotels and travel firms ensure a stress-free visit, while our dedicated team ensures excellent treatment and personalized care for every patient. NABH, the hospital is recognized earning awards and appreciation for compassionate care. Delegates from Iran, Myanmar, Kenya, the Sultanate of Oman, Uganda, and Zimbabwe visited our institute in 2023, as they were a part of their participation in the G24 Health Working Group and Ministers Meeting held at the Mahatma Mandir Convention and Exhibition Center, Gandhinagar. What our patients say. I traveled from the USA to Ahmedabad, UNMICRC Institute of Cardiology for my heart surgery, and I couldn't have been happier. The team here made me feel at home. The care was exceptional, and now I am healthier and stronger than ever.
My baby here is called Mark Finley Ochich. He came from Kenya. Our baby here who had a large BSD. 4 months with him when he was okay. Then I wanted to know why. I consulted a doctor, and that's when the doctor told me that he did some echo on him and told me that he has large BSD. There's a big hole in his heart that need to be repaired. We need to find specialists who can close that hole. It's not possible to be done here in Kenya. Collect the few money that we are having and we came here, and the operation was done very successful. My son now is okay, he can breathe well. I'm very grateful and thankful to all the staffs in this hospital.
UN Mehta Heart Institute serves international patients worldwide, offering world-class cardiologic care. Healing hearts, transforming lives beyond borders. Your heart's health is our priority.
મને આપના વિશે ટૂંકમાં થોડું જણાવશો?
હું નયન કુમાર કંડોલિયા અને મારી વર્ક છે રેલવેમાં સાબરમતી અને મારું ટેકનિશિયનનું કામ છે. બધું ટેકનિકલ કામ છે, હાર્ડ વર્ક જેવું બી હતું.
તો નયનભાઈ, તમને તકલીફ શું થઈ હતી અને તમને કઈ રીતે ખબર પડી આ કાર્ડિયાક રિહેબ સેન્ટર વિશે?
મને એવું થયું કે ડિસેમ્બરમાં મને થોડુંક શ્વાસ લેવામાં તકલીફ થઈ હતી, ચાલવામાં, સીડી ચડવામાં. મતલબ એ પહેલાં હતું જ નહીં ડિસેમ્બર પહેલાં. તો અચાનક થયું, તો એના માટે અહીંયા ટ્રીટમેન્ટ કરાવવા આવ્યા. મારા કઝિન છે અલ્પેશ સરવૈયા, એને રિપોર્ટ મોકલ્યો હતો ઇકોનો, તો એના હિસાબે આગળની ટ્રીટ કરાવી.
અલ્પેશભાઈથી તમને ખબર પડી કે અહીંયા રિહેબિલિટેશન સેન્ટર છે?
હા, એનાથી ખબર પડી અને અહીંયા ટ્રીટ કરાવી. તો અહીંયા એક્સરસાઇઝ માટે બી અમને થોડા એડવાઇસ કર્યા.
અહીંયા એક્સરસાઇઝ ચાલુ કરતા પહેલા આપને કઈ કઈ તકલીફ થતી હતી?
એમાં શ્વાસની તકલીફ હતી, એકદમ અત્યારે નોર્મલ થઈ ગઈ છે. 5-7 સેશન કર્યા ને તો ટોટલી નોર્મલ થઈ ગઈ છે.
આપ અહીંયા કેટલા સમયથી આવો છો?
હું 10-11 સેશન થયા આપણા.
અને 11 સેશનમાં આપણે અહીંયા કઈ કઈ કસરત કરાવે છે? આપને શું ફાયદો થયો છે અહીંયા આવ્યા પછી?
સાયકલિંગ છે, ટ્રેડમિલ છે, વોર્મઅપ છે, ફિર વેઇટ છે, ફૂટ વેઇટ છે, હાથના વેઇટ છે, બધા જે આપણા છે એ બધા કરાયા છે. તો એનાથી ઘણો ફાયદો થયો અને 20% એમાં ઇમ્પ્રૂવ થયું. 5% એટલે 20 થઈ ગયું અત્યારે. તો અત્યારે કદાચ વધી બી ગયું, એ મને ખ્યાલ નથી.
ઓકે. અને આપ અહીંયા આવો છો તો અહીંના સ્ટાફની વર્તણૂક અને એમાં આપને કોઈ?
નહીં, એકદમ મસ્ત સ્ટાફ તો પૂરો એકદમ સરસ છે. એકદમ રિસ્પેક્ટથી વાત કરે છે અને બધાને, હું મારું નથી કહેતો, બધાની સાથે બિહેવિયર બધાનું સારું છે.
અને તમારે બીજા કોઈને સજેસ્ટ કરવું હોય, તમારા ધ્યાનમાં કોઈ કાર્ડિયાક પેશન્ટ હોય, તો તમે રેકમેન્ડ કરી શકો કે યુએન મહેતામાં આવે?
હા, બધાને અત્યારે સ્ટાફમાં મેં મારા કેટલાને કહી દીધું છે કે બહુ મસ્ત છે એક્સરસાઇઝ વગેરે, તો જવા જેવું છે. મેં કીધું જે વસ્તુ મારે ત્યાં નથી રેલવેમાં, ફિઝિયો તો મારે ત્યાં બી છે, પણ એ વસ્તુ ત્યાં નથી આ બધી. એટલા માટે હું અહીંયા આવું છું, એટલું દૂર સાબરમતી ત્યાં અહીંયા.
નયનભાઈ, ઓવરઓલ યુએન મહેતા વિશે તમારો શું મંતવ્ય છે?
અમે ડિસેમ્બરમાં જ્યારે હું અહીંયા આવ્યો ને 19 તારીખે બતાવવા, ત્યારે ઓવરઓલમાં તમે જુઓ તો 19 થી 27 એડમિટ થયો ને, તો એકદમ સેમી ડિલક્સ રૂમ રાખેલો હતો. ત્યાંનો સ્ટાફ બધો એકદમ મસ્ત, મતલબ બધી ટ્રીટ એવી થઈ ને કે હું અહીંથી પહેલે દિવસથી જ ઇમ્પ્રૂવ એવું લાગે ને. હું 27 તારીખ સુધીમાં તો મને એવું લાગે કે મારું બધું હોશ થઈને ક્લિયર થઈ ગયું છે. તો બધો સ્ટાફની સાથે મતલબ મસ્ત રહી ગયો. અને
થેન્ક યુ સો મચ નયનભાઈ, તમારો ટાઈમ આપવા માટે. તમારી યુએન મહેતા માટે કંઈ કહેવું હોય?
યુએન મહેતા બેસ્ટ હોસ્પિટલ છે, એશિયાની નંબર 1 હોસ્પિટલ છે. તો હાર્ટની જેને બી ટ્રીટમેન્ટ કરાવી હોય તે અહીંયા જ આવે, હું એવું બધાને સજેસ્ટ કરું છું. તો એના માટે યુએન મહેતાને
ગુડ મોર્નિંગ.
गुड आफ्टरनून सर.
गुड आफ्टरनून.
मैं आपका नाम जान सकती हूँ?
ऋषि कुमार सुंदरदास ओछवानी.
ओके. यहाँ पे ये कार्डियक रिहेबिलिटेशन है, इसकी जानकारी आपको कहाँ से मिली?
ये ऑपरेशन के पहले मैं यहाँ पे दिखाने आया था, तब मेरे को वाल की तकलीफ हुई और नसें ब्लॉक हुई, वो बताया गया.
ओके.
तो 25 तारीख के बाद मैं यहाँ पे एडमिट हुआ था. तो 1 तारीख को मेरे को ऑपरेशन हुआ था, वाल और बाईपास दोनों का.
ओके. उसके बाद?
हाँ से उसके बाद फिर ऑपरेशन के बाद इन्होंने जैसे ही ओपीडी में बताने आया, 3 नंबर ओपीडी में कार्तिक पटेल के यहाँ से, तो उन्होंने एक्सरसाइज का लिख के दिया था, भाई 106 में जाना है आपको एक्सरसाइज के, वहाँ पे आपको बता देंगे क्या क्या करना है.
ओके.
ऑपरेशन के बाद.
ओके, ठीक है. यहाँ पे कार्डियक रिहेबिलिटेशन मतलब ये डिपार्टमेंट में आने से पहले आपको क्या क्या तकलीफें थी?
यानी सीढ़ी जब चलता था तो थक जाता था, धड़कनें बढ़ जाती थी और समझो कभी कभार चक्कर भी आने लगते थे. वो
उसके अलावा कोई दूसरी तकलीफ
नहीं?
थी?
ऐसी कोई नहीं, बाकी सांस फूल जाती थी बस चलने में, यहाँ दौड़ने में.
ओके ओके, ठीक है. अभी आप यहाँ पे आ रहे हो तो ये स्टाफ का मतलब स्टाफ का स्वभाव और ये एटमॉस्फेयर आपको कैसा लगता है?
बहुत अच्छा लगा. जब मैं पहले दिन आया था तभी बहुत अच्छा लगा था. पहले ही दिन पे जब एक्सरसाइज किया था फर्स्ट डे,
हाँ,
तो बहुत अच्छा था, मोटिवेशन हुआ था उस टाइम, बहुत ही अच्छा लगा था. घर से अच्छा फिर यहाँ पे लग रहा था करने में.
अच्छा.
हाँ.
ओके ओके. फिर यहाँ पे मतलब आप अभी कसरत कर रहे हो,
हाँ,
तो कसरत के बाद आपको क्या क्या फ़ायदे हुए?
यानी पहले तो समझो थकान होती थी चलने में, अभी वो नहीं हो रही कभी भी. और पूरा दिन ऐसे अच्छा ही जाता है, कोई दिक्कत नहीं है, अभी कोई तकलीफ नहीं है।
इसके अलावा कुछ?
नहीं, ऐसे कोई तकलीफ नहीं। ओके।
ओके। और यहाँ पे जो कसरत में अभी आप आ रहे हो तो आपको
हाँ।
कौन सी कसरत करवाते हैं?
एक तो लेग साइकिल है, आर्म साइकिल है, और ट्रेडिंग, और एक ये कूल डाउन।
कूल डाउन। आप जब आते हो उसके पहले कुछ करवाते हो ऐसा कुछ?
नहीं, बस वैसा वैसे ही चलता है।
ओके।
Excellent।
ठीक है। आप उसके बारे में कुछ कहना चाहोगे कि पहले आप क्या कर सकते थे और अभी आप नहीं कर सकते, और मतलब आपकी फिजिकल एक्टिविटी और कार्डियक क्षमता के बारे में कुछ कहना चाहोगे?
मैं जॉब करता हूँ, यानी बेकरी पे। पहले जब जाता था बेकरी पे तो थोड़ा थकान रहता था, पूरे दिन का खड़े रहने था। उसके बाद समझो जब ऑपरेशन
कितना घंटा, मतलब कितने घंटे की नौकरी थी आप?
10 घंटे की नौकरी है।
12 मतलब 10 to 12 आवर की ड्यूटी होती है। उसमें आपको मतलब खड़े रहना
है,
खड़े ही रहना है, बैठने का होता था उसमें?
इतना नहीं, कम।
ओके।
पर उसके बाद अभी जब ऑपरेशन कराया तो 3 महीने रेस्ट करने के बाद अभी 6 में समझो घंटे जाता हूँ, 3 बजे से 9 बजे तक। पर इतना ही थकान नहीं रहता है और अच्छा ही है। अभी जॉब चालू हो गया है, काउंटर पे खड़े रहने का है, और अभी है, कोई दिक्कत ऐसा नहीं है। अच्छा ही
उसमें सांस फूल जाती हो ऐसा
अभी,
कुछ होता
अभी
है?
कोई तकलीफ नहीं, पहले जैसे तकलीफ थी अभी नहीं है।
ओके।
अभी तो पूरा अच्छा ही है। और
बैकरी
यहाँ पे आने के बाद और भी अच्छा है, एक्सरसाइज करने के बाद जो भी आता है पूरा दिन अच्छा ही रहता है।
ओके। बेकरी में आप जाते थे तो मतलब आपको कोई हैवी चीज़ लोड भी मतलब उठाना होता होगा, तो उसमें कोई चीज़ में फ़र्क पड़ा है?
नहीं, अभी तो इतना नहीं है, अभी तो नॉर्मल हो गया पूरा। कोई भी चीज़ ऐसा कोई नहीं है, अभी नॉर्मल है पूरा।
ओके। और आपका ओवरऑल एक्सपीरियंस में अगर आपको पूछूं कि यूएन मेहता में आपका पूरा सर्जरी से लेके यहाँ पे कार्डियक रिहेबिलिटेशन का पूरा सफ़र अगर मैं आपको डिस्क्राइब करने के लिए बोलूँ तो उसके लिए आप क्या बोलोगे?
यूएन मेहता के लिए तो बहुत बढ़िया है। जब मैं आया था ऑपरेशन के लिए, जब ऑपरेशन के बाद समझो सर्जरी हुई, ये एक आईसीयू में था, तब से लेके मैं समझो डिस्चार्ज होने तक बहुत अच्छा था और पूरा ध्यान भी देते थे। उसके बाद फिर एक्सरसाइज के लिए यहाँ पे बोला गया और उसके लिए भी बहुत अच्छा ही था, और पूरी यूएन मेहता के आने सपोर्ट था एकदम, और देखभाल भी बहुत अच्छी थी, बहुत अच्छा था।
ओके। अगर किसी को अगर मैं बोलूँ कि आप अपने रिलेटिव को सजेस्ट करना चाहो तो कर सकोगे?
हाँ, मैं तो बोलना चाहूँगा कि यूएन मेहता ही सब आस है और बढ़िया है, सबसे बेस्ट।
ओके ओके।
ओके, यूएन मेहता के लिए बहुत बढ़िया, धन्यवाद, थैंक यू।
Discover Gujarat, where ancient healing traditions meet modern medical excellence. Offering world-class healthcare infused with timeless wisdom, Gujarat is a destination for rejuvenation. Explore iconic landmarks like the Statue of Unity and Asiatic lions while experiencing healing with heritage. Embracing the theme Vasudhaiva Kutumbakam, One Earth, One Family, One Future. The Department of Health and Family Welfare, Gujarat, provides comprehensive healthcare at Medicity, Ahmedabad, featuring the Gujarat Cancer and Research Center, Institute of Kidney, all ages, including pediatrics. The UN Mehta Institute of Cardiology and Research Center, established in 1982, has grown into India's largest super specialty cardiac hospital, offering world-class care. Guided by the visionary leadership of the Honorable Prime Minister, Shri Narendra Modi, the institution's excellent performance and health services are supported by the Honorable Chief Minister of Gujarat and the Health Minister of Gujarat. Guidance is also provided by the Principal Secretary of the Health Department of the Gujarat Government, the Chairman of the institution, and the Health Commissioner. Your heart, our priority. UN Mehta Heart Institute offers world-class cardiac care with innovative treatments, state-of-the-art facilities, and compassionate service. Committed to holistic recovery, we prioritize restoring your heart health and improving your quality of life. Why choose us? Our world-class cardiologists,
I, Dr. Nishtha,
And I, Dr. Priyanka,
Good afternoon. A very warm welcome to all on behalf of UNMICRC Institute of Cardiology and Research Center. Dr. Nishtha,
And I, Dr. Priyanka, we are delighted to welcome you to the symposium on enhancing heart health. The beat goes on. We are honored to have such a distinguished group of dignitaries and students joining us today.
we are here to celebrate and spotlight the power of cardiac rehabilitation in enhancing heart health. This year, our theme is Enhancing Heart Health. The beat goes on, which encapsulates our shared commitment to improving the lives of individuals recovering from heart events and procedures.
This week, we recognize the success stories and the unwavering spirits of our patients. We also acknowledge the vital roles of our healthcare professionals, the doctors, nurses, physiotherapists, and the support staff who work tirelessly to guide and support our patients every step of the way.
Whether you are a patient, a caregiver, a healthcare provider, or simply someone interested in heart health, this week offers a chance to learn, connect, and be inspired. Together, we can ensure that the heart goes on stronger and healthier than ever before.
So, let's commence today's event with the words of our dynamic and visionary director, Dr. Chirag Doshi Sir, HOD CVTS, UN Mehta Institute. We request you, sir, to address the gathering.
Very good afternoon to all of you. First of all, I would like to congratulate our physiotherapy department, cardiac physiotherapy and rehabilitation department, for conducting such a, I would say, symposium event, academic fest. Honestly, before I say thank to all the faculties and dignitaries who have come from and then spending their busy, taking a time out from their busy schedule. It's and that to be on a weekend or Saturday. This requires a lot of commitment, dedications, and I would say teaching like teachers who always believes in teaching, and they don't see time, they don't see days, they don't see holidays, and they are always available. So thank you so much for that. All all of you have come. I was just introduced that they have come from the different institute, different areas, different cities, and of course all the colleagues who are like within the institute, or some of the students have come from the other institute or other centers as well. So I want to welcome you on the behalf of our cardiac rehabilitation department. But having said that, what I personally believe and what I've seen, what I've experienced over the period of almost more than a decade, that our physiotherapy department, a cardiac physiotherapy department, is doing a wonderful job. I mean, they are so passionate about their work, and honestly, this is being a cardiac tertiary care center. This is I'm sure you all must be knowing that this is a pure cardiac hospital, right? We cater only cardiac patients, and in that category, if they can make their own space there, and they are developing they've in fact developed their department like any other super specialty department. So I want to congratulate, and I want to give that credit to their three, I think the what you call is the pioneers or the department founders. They're Madam Aisha, Dr. Falak, and Mihir. So thank you so much. You are doing all wonderful job, and obviously along with their all seniors who have been associated with them for years together, and they are also performing their duties day in and out. And I'm sure they are, like, I would say they are the troubleshooters. Why do I say they are the troubleshooters, or they are something which we can trust on whenever we have some difficulties, or difficulty in sense, suppose we want to start some new program, and we are looking for some doctors, or for that matter some I would say non-doctor administrative work, right? And I've yet to hear no from their department. We tell them that this is what you are supposed to do, this is your role, and they've always accepted it, and with gracefully, right? They never ever cried. They are never like, they are always positive. They are always in the front run. So I am so much thankful to this department, and they are honestly, we always keep telling that their staffs, obviously staffs, they are the backbone of this hospital or any other institute for that matter. But I would say these people, the physiotherapy department is actual a backbone of our hospitals. So thank you once again for this. And we all know that obviously this is going to be again cardiac rehab symposium, right? So, and cardiovascular disease is one of the very leading cause of illness, not in the state of Gujarat. Yes, Gujarati have more this issues undoubtedly, but it's a world leading disease and world killing disease. So what is important as a surgeon, I can tell you, or as a clinician, is important that clinicians, what we believe that okay, once we have touched these patients, once we operate these patients, or for that matter, if we do a procedures, and my job is done or our job is done, right? But then we don't think that how this patient is going to be in when they go back to their routine activities or when they go back to their dailies. What today's world is all about, the faster, the more faster and complete recovery. And I strongly believe this would not be possible without your intervention, without your support, and without your skill and knowledge. And this is why this symposium is going to definitely be very fruitful for all of you who are here today and who are listening maybe live today. We are live, right? So just a piece of advice or request. Next 2 hours, be here physically, mentally, be very focused, be attentive, okay? And I'm sure these experts, they are really good in their subject, so they would in fact tell you their entire journey's experience in this next 2 hours, right? So some of my colleagues surgeons are here, some of the administrators are here, some of the cardiologists are also sitting here. So don't hesitate. Whenever you have any doubts in your mind, do not hesitate to ask them, okay? Be filled. This is something we always work like a family, right? So don't shy away from asking questions or your doubts, right? You can always ask to your teachers, you can always discuss with your colleagues, right? Don't feel that they are our bosses, we cannot ask them, they are our head of the department, we cannot go and ask them directly. This is a very important, because on Saturday you all are here, on your weekends you are here, so use this time, use this in a very productive way, okay? And Mihir, once again I want to congratulate you and your entire department along with madams and all who are sitting here in the front row and the back rows. You people are doing amazing work, and keep doing what you are doing, right? With that note, I really want to congratulate once again. I wish you all the best for your great future. Thank you.
Thank you so much, sir. We would like to request Dr. Aisha Mullah ma'am to felicitate Dr. Chirag Doshi, sir. We would like to express our sincere gratitude for your inspiring address, sir. It is our immense pleasure to welcome our chief guest, Dr. Nehal Shah, sir, the esteemed chairperson of Gujarat State Allied and Healthcare Council. Sir is a visionary leader with exceptional dedication to improving the healthcare landscape. His efforts have made a lasting impact on the industry, and we are truly honored to have him today.
We would request Dr. Naitik Patel, sir, the Chief Administrator of UN Mehta Institute, to kindly felicitate our chief guest, Dr. Nehal Shah, sir. Thank you, sir. We would like to request Dr. Nehal Shah, sir, to say a few words.
afternoon, and thank you UN Mehta Institute of Cardiology and Research Center for inviting me. Just when I was coming in the car, I was thinking कि कहाँ से शुरू करूँ, from where should I start to speak. So for a physiotherapy perspective, I should say एक गुलजार साहब का 2 लाइन याद रह गया, एक गाने का ही है, and it is very much related to cardiac rehab. आप उसी एंगल से लीजिएगा. So पाँव के तले कभी दिल पड़ा मिले अगर, चूम कर उठाइए खूब देखभाल कर, और जो कोई पूछ ले तो क्या राह से उठाया है. So this was one of the favorite song at our generations, but this is a fantastic line. You can relate with whatever you do in cardiac rehabilitation. And morning only I was talking to Mihir that भाई गई काले वेलेंटाइन डे હતો એટલે આજે સિમ્પોઝિયમ રાખ્યો છે. So it's a joke apart. But yes, as sir already told, heart disease is one of the leading cause in entire world. But yes, nowadays interventions and lifestyle management, proper lifestyle management definitely makes a heart patient a healthy patient, right? So as the topic says, enhancing heart health. So what can we do for enhancing heart health? So I should just say in very brief, because sequence of lectures are going on, sequence of discussions will be going on. So simple, what I would say that these are the 5 fingers, and these 5 fingers easily says how to enhance the heart health. First is, can anybody says diet, right? So diet is what we are eating. तो क्या होगा? So we have to consider what we are doing. That is first thing, and then we should go for what we should eat, right? So yeah, if we are not a heart patient, then we should not be a heart patient. But if we are a heart patient, then we should be out of that. We should be out of those problems related to heart. So we should have very good healthy healthy diet habits in our diet. We should have proper portions of fruits, vegetables, lean protein, healthy fats, and simultaneously along with that we should have a limited access of processed food, packaged foods, sugary drinks, and saturated fats. Now second finger, if I would say, that is physical activity. How many of you are doing regular exercises? And how many of you are not doing regular exercise? So if you are not, then start just with 5 minutes a day. I am not saying कि भाई आज ही आज आप आधा घंटा जाओ या जिम शुरू कर लो. No, you just start with 5 minutes, then you increase your exercise, let's say every 3rd day. That will be easy. और कब आप इतने फिट हो जाओगे? आज मेरे सामने ज़्यादा नहीं देखना, 6 महीने बाद दोबारा देखना, because I had some health problem earlier. So, but I am a half marathoner, regular half marathoner, right? So physical activities, yes, it's a very much crucial, very much important, and everyone should do. ऐसा नहीं कि फिजियो बन गए हम तो इस पार है पेशेंट को बोलते रहेंगे, not like that, right? And if you are doing regular exercise, then also you have to increase your exercise in a regular manner. क्योंकि हम जैसे I regularly say to my OPD patients कि जैसे जैसे उम्र बढ़ती है आप एक्सरसाइज भी बढ़ाओ, right? So physical activity is my second finger. Then third thing is stress management. So बच्चे से लेके बूढ़े तक सबको किसी ना किसी का स्ट्रेस होता ही है, right? But chronic stress, आपकी बात अलग है सर. But yes, chronic stress always leads to heart, high blood pressure and cardiac diseases, right? So uske liye bhi you should have some time of deep breathing, pranayam, yoga and that kind of exercise. Fourth is sleep. ऐसा नहीं कि आज एग्ज़ाम है, कल एग्ज़ाम है तो आज 2 घंटे ही सोते हैं, बाकी के दिन 6, 7, 8, 9, 10 घंटे सोते हैं. Not like that. You should have regular enough sleep for yourself. जितना बैलेंस से रहेंगे उतना बैलेंस से जिएंगे तो उतना रिलैक्स्ड होके रहेंगे हमेशा, राइट? एंड फाइनल फिंगर और इट इज़ अ थंब. सो थंब इज़ व्हाट? दैट इज़ रेगुलर बॉडी चेकअप. पहले 4 में तो ऐसा बोल दिया कि भाई फिजियो आ गए, डाइटिशियन आ गए, बिहेवियरल थेरापिस्ट आ गए, साइकोलॉजिकल थेरापिस्ट आ गए, योगा वाले आ गए, लेकिन रेगुलर हार्ट चेकअप और रेगुलर बॉडी चेकअप इज मोस्ट इम्पोर्टेंट फॉर दिस, राइट? एज एन वी आर ग्रोइंग, हमारा रेगुलर बॉडी चेकअप होना ही चाहिए इन विच एवर द प्रोफेशनल फील्ड्स वी आर. इन द सेम वे एज अ प्रोफेशनल यू हैव टू से टू योर पेशेंट्स कि भाई रेगुलर चेकअप तो होना ही चाहिए. At till certain age, every year after 40 or 45 or 35, you say every twice in a year, हर एक फिजिशियंस को भी मिलो या ऐसा कुछ पर्टिकुलरली पैकेज. जैसे यूएन मेहता है तो दे आर हैविंग क्वाइट पैकेजेस कि भाई साल में कंप्लीट बॉडी चेकअप होता ही है और उसके साथ कार्डियोलॉजी वगैरह कंसल्टेंट भी होते हैं. सो दैट इज मोस्ट इम्पोर्टेंट, राइट? सो these are the 5 things which makes a feast or that can punch to anyone also, right? So everyone, all of us should have a pledge. Daily आपको वो याद रखना ही है कि भाई we will make our heart healthy, और heart healthy होगा तो सब कुछ healthy ही होगा, right? और also दूसरा चीज़ बहुत इजी में बताओ कि गुजराती में भी एक कहावत है कि पानी पहला पाड़ बांधवी, और in the same way in English we can say prevention is better than cure. और अगर उसको और इजी करते हैं कि भाई प्रॉब्लम को आना ही नहीं चाहिए और प्रॉब्लम आए तो सॉल्व करे, उससे अच्छा है कि प्रॉब्लम आने ही नहीं दीजिए, राइट? सो दिस इज समथिंग विच इज वेरी ब्रीफ. आई एम टॉकिंग अबाउट एनहेंसिंग हार्ट हेल्थ. नाउ लेट मी से समथिंग अबाउट GSAHC, गुजरात स्टेट अलाइड एंड हेल्थ केयर काउंसिल. सो on 20th December 2024, Gujarat government has notified this council under the NCAHP Act 2021, that is National Commission for Allied and Healthcare Professionals 2021, that is the act. And let me say this is going to be the biggest council, as along with physiotherapy there are other 56 courses in this act. So we are going to regulate all these 56 courses. It includes physio, occupational therapy, dietitians, behavioral science, all the allied health cares, all the assistive technologies, all medical lab technologies, medical transcriptionists, biotechnologists, gene technologists, all these will come under GSAHC, right? And those who are registered physiotherapists under GSCPT, I request them to go for NCAHP website and enroll yourself in that, so that it will create a very good data. And once the rules and regulations are coming, I'll say within 1 or 2 months, the council will be in act 100%. Right. So once again, thank you, UN Mehta Institute of Cardiology and Research Center. Thank you.
Thank you so much, sir.
Now, let's start with the lecture series. It's an honor to welcome our first speaker, Dr. Pratik Manik sir, Associate Professor in CVTS, UN Mehta Institute of Cardiology and Research Center, who will be presenting on the topic From Operating Room to Home, Bridging the Gap with Cardiac Rehabilitation. Sir has a vast experience in the field of cardiothoracic surgery and specialization in performing heart transplant surgeries. We would also like to welcome our distinguished panelist on the dais, Dr. Karthik Patel Sir, Associate Professor in Cardiovascular Thoracic Surgery, UN Mehta Institute of Cardiology and Research Center. He brings forth extensive expertise in the specialized field of CVTS. He is proficient in executing cardiac surgeries and stand as a beacon of excellence in the field. We would also like to welcome our second panelist, Dr. Sweetie Shah Ma'am, Assistant Professor, SBB College of Physiotherapy. She is a trailblazer in the field of physiotherapy and has mentored countless students and guided numerous PGs and PhD research projects. Thank you so much, sir.
A very good afternoon to all the audience and all the respected seniors, dignitaries, my colleagues from surgical department, cardiology, and good to see a huge crowd is gathered over here. So I'm very happy to be here. And special thanks to the organizers, Aisha Mullah ma'am, Mihir and Falak, and the entire physiotherapy department to consider me to talk and discuss out the things with you. So let's directly jump to the topic. My topic is from OR, the operating room to home. Bridging the gap with the cardiac rehab. Much a talk about and much a known topic, but not much practically practiced topic. I'm Dr. Pratik Manik. I'm an associate professor in Department of Cardiothoracic Surgery. So, why do we say from OR to home? Why don't we say that the patient is just operated, is good? So whenever we see a patient in the outpatient department, I would like to discuss rather than discussing the slides out. You can read the slides parallel. So see, whenever we see a patient in the OPD, the patient never comes that कि सर ये वाल का ऑपरेशन है, वाल बदल दो, या वाल का ऑपरेशन है, ठीक कर दो. Patient comes with a complaint that he is doing something, he wants to do something and he is having some limitations in doing that. It's we who tell them that there is some valvular problem, or there is some coronary problem, or there is a failure therapy, or there is some problem with the heart. He doesn't know that. What he wants is वो जो activity कर रहा है, whatever activity he is doing, that is being limited. And what he wants from us, that he goes back home and does the same activity without any symptoms. He's coming to the hospital to just come here and go back and do the same thing what he was doing. He's loving his routine, he's loving his life. He wants that same thing to be there. He doesn't want that you do the surgery and then after the surgery he's stuck to the bed and he's just watching a TV. I know many of them do like that post-operatively. We will see the reality also. But the fact of the matter is everyone. And that is, see, the cardiac part is much more ignored because even not much from the physician or surgeon side, we are much involved in the rehab. Moreover, there is some fear that a cardiac surgery has been done. The rehab is not that possible, or the rehab can take a back step. Saving life is more important than getting back to life. Same thing अगर आप ortho में सोच के देखो, if a patient is getting operated and he is not able to move around, the patient will kill you. He will directly वो तुम्हें legal case कर देगा कि तुमने तो बोला था चल के दिखाएंगे, चल तो पा नहीं रहे. So this same thing should develop in the cardiac rehab also. Patient has to be aware, the physician has to be aware, the surgeon has to be aware, and simultaneously you guys are aware, but then more and more involvement and more participation is required, both from patient as well as from the rehab side. So yes, we are aware that cardiovascular disease is on the rise. There is a lifestyle disorder, more and more comorbidities. So you mean more and more cardiovascular diseases. Younger patients with more comorbidities, younger patients with cardiovascular disease, more of the life years they are going to spend with this disease. So more of the life years means more of the life years they're not going to sit in the bed. For example, if you diagnose a patient with a heart problem, he will stay on the bed for one month, 2 months, 6 months, 1 year. After 1 year, he will get frustrated and tell you, sir, this is not what I wanted from you. This is not what I wanted from the surgery. I want to go back to my normal life. So that's where the role comes. You have to bridge the gap with the cardiac rehab. It's much a talk about thing, but reality is different. We are not able to give that to our patients still. So it has a major role, especially in long-term outcomes and ultimately the quality of life. The quality of life has to be at least the normal, at least back to normal. Not just he expects कि अभी जो चल रहा है उससे बेहतर हो. He wants to be better than what he is right now. Right now he is with a problem, but still he is doing something. He says that if you are curing me of a problem, I should be more better than what I am right now, post-surgery. So what do you mean by cardiac rehab? It is a complex interprofessional intervention. Interprofessional, why do we say? Because cardiac rehab comes after and before the part, but the center point is the patient is being treated for some disease. So every point of the contact of the patient in that disease process is a part of a cardiac rehab. And the rehab has to be customized to the individualized patient as well as to individualized disease pattern or the pathophysiology of the disease. उस हिसाब से you have to plan, be it ischemic heart disease, or the patient is directly landed up into heart failure, or the patient has undergone a surgery. For example, post-op surgery patient is there and patient is already having pain and you are on the first day saying, come on now, get up, sit on the chair, start walking. He cannot do it. So it has to be individualized as per the patient. He has pain, so you have to go slow. If you tell them you don't have to do these things, he will be very well aware. Then let him do the other things. He will confidently be able to do that. Or if the patient has undergone a stenting or a percutaneous intervention, like an angioplasty. So what is our aim of a rehab? So we want to limit the psychological and physiological stresses of cardiovascular disease. We want to improve it. We want to bring him out of that fear, the psychological barriers as well as the physiological barriers that is limiting his activities. At a long term, we want to reduce the mortality out of it. We want to improve the cardiovascular function as well as the entire bodily function so that the best possible quality of life can be achieved by him. What does it do? It also helps in halting the progression of the disease. Like sir said, that primary prevention karna hai, physician se milna hai. At after some age you start doing exercise, you start doing this and that. So the rehab not only brings you out of the disease, it also prevents and it also helps in progression of the disease. If the disease is going to progress by the same rate, then the patient will say, better I'm at home rather than coming to you, getting at the treatment at the hospital and then going back again with some problem. And this how it increases the patient's self-confidence and he now gets back into his routine. He can play, he can do his job, he can do all the routines. So that is more important for us. So if you look at the components, so there are many components that you have to take care of the vitals, you have to take care of the patient physique, the weight, entire assessment of the patient, nutritional status of the patient, the blood pressure, the diabetes, how psychologically is motivated, how much is the family supporting the patient for the rehab, how much the physical activity is possible, and then how much exercise training is possible and how the exercise training is going to progress further. So any patients with a heart condition is a candidate for a cardiac rehab. But there are some of the conditions which we want to avoid. What are these? So if the patient is having unstable angina, what do you mean by unstable angina? If the patient is sitting at rest and is having angina, means the chest pain due to a coronary artery disease, you should not do it. If it has a decompensated cardiac failure, if the patient is not, if the medicines or the therapies or the lifestyle is not able to, achieve a compensated phase of the heart failure, then decompensated phase you cannot do a rehab. He's having some of the other ventricular arrhythmias, he will be having problem, he may have giddiness while he's doing rehab. Severe pH, patient may start developing hypoxia with the patients with severe pH. If there is any thrombus in the heart, or if there is any history of pulmonary embolism, or is a high risk of pulmonary embolism, some of the obstructive lesions like obstructive cardiomyopathy or obstructive valvular disease, when the blood is not flowing across the valve, then you cannot do a rehab. You cannot make the body demand more blood when the heart is not able to pump blood. Or there are some systemic factors or the musculoskeletal physiology is such that you cannot put the patient to a rehab. So it's definitely a team approach. First of all, the patient is needed. The patient has to be motivated. The patient's involvement is definitely needed. The family has to support, because in-house or inpatient post-operative rehab will be taken care by the doctors, nurses, the staff. But at the home, the patient needs the support of the immediate family so that he is motivated, he is confident to do that. The surgeons and physicians' role, it is very important because see, whenever we do a surgery, if my patient is getting operated today, for example, he is on ventilator for tonight, we are just assessing everything, everything is fine, cardiac is, everything is fine, no complication, no bleeding, anything. Next morning, if he's getting extubated, the patient is talking with me, I'm going on a round, and if I feel that my patient is not active, he is not very much, cooperative, he is not motivated, or he is feeling feared and all, then even if I go and do another surgery, I have a nagging thought in my mind that if the patient is not motivated in a day or two, or if he doesn't do the immediate rehab, he is going to land up into complications. We know that. So the moment with the next day we feel that the patient is totally fine, vitally stable, there is no surgical problem is there, we immediately call our physiotherapist, चलो इसको chair पे बिठा दो, इसकी physiotherapy शुरू कर दो, इसको spirometry करवा दो, some or the other thing, just the hand movement or just the limb movement, something. The patient has to be motivated right from the day one. The moment you think that the patient is ready, start rehab. So surgeon and physician has to be involved, and we are usually involved. We are involved in directing others that please do the rehab. But we have a thought constantly in our mind that the rehab is an essential part. So the physiotherapist, the cardiac physiotherapist, they are the major role. And the nutrition part and the ancillary part is taken care by the dietitians and the nurses. They are a part of the team. They are not away from the team. So classically, there are 3 phases of any cardiac rehab. First phase would be the clinical phase. The second phase would be outpatient aggressive phase. And the third would be considered as a maintenance phase or the post-rehab phase. So the phase 1, a lot of things is written, but phase 1, just one thing, the patient is in the hospital, it is in-house. Once you are ready, once the surgery is done or once the therapy has been given, the patient is compensated, he is stable, he is ready for the rehab, you start rehab. So what do you have to do? See, the most important part, we have to assess the physical ability of the patient, whether he is still ready, whether he is ready to do the rehab. If the patient is already, having severe pain, some arrhythmia is going on, some hemodynamic derangements is going on, and if I tell the physiotherapist come and do a rehab, he will say that are you crazy? We cannot put the patient to the risk. So we need to assess the patient whether he's stable, he's physically able, at least he should be able to do that. He should be motivated. If he feels he's not able to do that, he should be motivated. Tolerance has to be developed. And what it starts with, non-strenuous exercises which are on the bed or just bedside, sitting on the chair, moving the limbs, talking with others, doing physiotherapy, doing with spirometry, limb movement, all that. And then we gradually put him to activities of daily living. What do we mean by that? Once the patient is out of the ICU, there is a constant, upgradation of the rehab going on. Like chair sitting ho gaya, then you go around, walk around the bed. Then the patient walks in the ward. Then you ask him that you go to the washroom by your alone. Do your brushing of the teeth you're alone. Go and have a bath. Come back. If you feel any problem, just tell us. Then the whole day the patient roams about. He is told that do this thing, do that thing. So what we want, that whenever he goes home, he's fully confident. At least the basic activities which he's supposed to do at home, the family should not fear that. The patient should not fear that. Right. So in this phase, it is important that before discharge, the familial discussion also happens. It's not like you just explain the patient that, see, these are the components of rehab, do this thing, do that thing. Now he will go and do everything confidently at home, but then his relatives is worried. Yeah, he is doing this, he's doing spirometry, he's moving his limbs. I don't know, his heart will go weak. And the next week when the patient comes in the OPD, he's like, he doesn't listen, he does not sit down, he's constantly moving about. This is the 80% of patients relative complain that he's not sitting at one place. We don't want that. We don't want the patient to sit at one place. But see, the family has not been explained. The immediate relatives don't know what is the importance of rehab. They have not been counseled about that. And so they have to counsel, they have to be educated, and then the discharge has to be planned. So whenever we say that, see, especially the rehab part is more important discharge. What happens is that many a times the cardiac rehab physiotherapist is doing, but many a times the patient gets discharged, they don't know the patient is already discharged. So it's important, they are a part of the discharge policy. See, whenever you do a discharge, we do write the medications, the surgeon sees the wound, assesses the patient completely. Many a time the dietitian comes, explains all the dietary requirements. But we have to put that thing in a routine that the rehab person comes, the physiotherapist comes, he knows that the patient is getting discharged, what is to be explained before discharge. Well, half of the time he comes for the round, he doesn't know that the patient is already discharged. That happens here also, and that is practically not, that is not expected also, and even we don't want that thing to happen. I don't say that they are not involved. He came and he came to know that the patient is discharged. It's not that he didn't come, but he has to be informed. So that has to be involved. There has to be involvement from our side also. We have to intimate them. The patient is discharged. Come and explain them what is to be done at home. So the next phase is the outpatient rehab. It's said up to 3 to 6 weeks. Maximally it can progress up to 12 weeks. So once in the outpatient department, the patient has been cleared by the surgeon or the physician that yes, now the outpatient rehab can continue. He is very well stable. Stitches are removed. Echo is fine. X-ray is good. He is up and about. Everything is fine. Medicines are controlled, well optimized. So you start the outpatient rehab. So what happens is now we are focusing on the factors that are limiting his regular physical function. For example, he was driving a scooter before that, or he was driving a car, he was driving a bicycle, but now he is not able to do that. So now that phase comes when you want to put him to his previous activities. So this is a part of an aggressive phase. Your initial clinical part has been taken care of. He's the routine thing he's doing. Self-care is taken care of. Now he wants to roam about. He wants to go to the garden. He wants to talk with people. He wants to travel. So then that part has to be taken care over here. And any again comorbidities has to be taken care of, like the blood pressures are shooting up or some lung function is taking a problem in doing the rehab. Then you have to take care of that. So it is a more rigorous, a patient-centered therapy. And again, all the things come into play, like you have to inform them, you have to advise them, a tailored training program is devised for them, and then you have to give them what time they have to relax, what time they have to do the rehab, all that. So coming to the third phase, so it's the post-rehab phase or the maintenance phase. It's getting more about, the patient then starts self-monitoring. Now if you tell the patient that you in the second phase, you tell him now you start climbing the stairs. Okay, so he starts climbing the stairs. He does that confidently. Now in third phase, he will come and say, you told me to start climbing the stairs. I'm doing that, but I don't know how many stairs I should climb. Should I go to first floor or second floor or third floor or fourth floor, or how much I should exercise? So now if the second phase is taken care of, the patient will be very well oriented. What limitations do I have and where I have to be self-aware of that. So now there comes the phase of a self-monitoring and becoming more independent from us. Now he gets into a self-rehab pattern. He climbs up to 2 stairs. He feels that today my 2 stairs are enough. So then he has to realize that now if I have to progress further, then I have to again, be more independent and more aggressive in whatever has been taught to me, like strengthening or the aerobic exercises or improving the flexibility of the muscles and the entire body. So again, nothing much required. You just have to encourage the patient. He will just come once in a week or once in 15 days or once in a month. You just have to give encouragement, ask him to maintain an active lifestyle, continue the exercise. And again, we have over here we have an online monitoring program also, where we can do a Zoom meeting and we can do a rehab. It's very well coordinated. So all this this phase is like maintaining and then continuing further. So now the complications of rehab, very important, because the most important, because even the physiotherapist feel that a CABG has been done or a valve replacement is done. If I give him this exercise, if he lands up into some problem, I'll be in trouble. So it's never like that. Most of these patients are compensated well. The medications are optimized. They have been cured of a disease. They have not been given a disease. So if they are cured of a disease, they are definitely a better candidate for rehab than before. So literature says that the complications are very rare, like 1.3 per million hours of the exercise. And moreover, we have seen that the complications in the rehab arm in most of the trials has been lesser when they have compared with the control arm. So again, we look at the clinical benefits. So it increases the quality of life, it reduces the healthcare costs overall. So see, once the patient is independent to do a rehab and he is doing everything well, he will stop coming to you. He'll just come once in a 6 months or once in a 3 months. But if he is not confident, if the relatives are not confident that he has recovered, वो हर हफ्ते तुम्हारे पास आएंगे. And if his costs will increase, the healthcare cost will increase, the medication cost will increase, the overall cost will increase. Your engagement will also increase. Your time will be occupied more. So the more the aggressive the rehab, the better the quality of life, lesser is the cost, more physiological benefits, exercise training, it improves the mixed venous oxygen, the VO2 max, the endothelial function improves, the overall long-term outcomes improves, the myocardial reserve flow improves, and the better part, the cardiac rehab helps them to get rid of the old habits, like it brings down the smoking, it reduces the body weight, the blood pressure starts optimizing, the lipid control is better, the sugar controls are better. So one thing, a lot of things can be achieved with that. And a psychological benefit also, because everyone knows the more you exercise, the more you get rid of the depression, and self-confidence increases. So even in post-rehab or in post-surgical phase, there has been seen there is a reduced incidence of depression. Majority of the patients undergo the surgery, they have psychological barriers more rather than the physical barriers. So once the patient is aggressive, you have achieved the phase 2 very well, your patient will not have those psychological barriers. It reduces hospital admissions, and all cause mortality improvement has been seen in the patient with heart failure also. So our goals, again, it reduces symptoms, improves capacity, and most important, the long-term outcomes, because it improves the long-term outcomes and reduces the progression of disease, as well as it reduces the risk of sudden death and any risk of reinfarction. But again, we know the reality is not true. Whatever said and done, everything is good, but in reality is not that good. The patient participation is very low in cardiac rehab. Nearly 30-35 literature wise also very high. I would say nearly 15-20% would be the participation rate by the patients, and especially in the secondary prevention programs after any intervention, because the psychological barriers are very high. And what are the reasons? Would be like a low referral rate from the surgeon itself. So if in the OPD the patient comes, surgeon is he just sees the blood pressure, the sugars, the medicines, everything is fine, the echo is fine, the X-ray is fine, the relative is counseled well, because half of the time it's important to counsel the relative rather than the patient. The patient is always not much in the worry rather than the relatives. So there are very low referral rates in Western countries, not in our institute, but in Western countries they have seen that the cost of the rehab is going up very high, and the companies or the insurance policies, they don't cover the rehab costs. Patient motivation is always less. That will be less, but that's on our part. We have to motivate them. And program site accessibility is still less, especially in our setup, where you don't have a setup like UNMICRC or the experts like Madam Aisha or the Mihir sir or Falak ma'am or the entire department that they take care of the rehab. So it's very important that patient do have the access also to such a rehab. So what are the patient barriers? So most of the studies have shown that the psychosocial barriers are more. Patients say we don't have time much for the rehab. 1 घंटा आना है, फिर आधा घंटा rehab करना है, फिर 1 घंटा travel करना है. It's not possible. There is a fear of exercise. Hardly I've got a bypass done. इतना risk वाला surgery था, I got out of it. Now I cannot risk more exercise and get more into trouble. And as we see, as sir told that most of our patients, they don't do exercise. Even if they're at the age of 40-45, they are not active. Everyone is not a marathon runner and not even a treadmill runner. So he already has a fear of exercise. He doesn't have susceptibility to exercise, or he's not exposed to exercise. तो वो benefits उसको पहले ही पता नहीं है. He doesn't know the benefits before, so he's not going to take the benefits afterwards also. If he's not aware before the surgery, he's not going to be aware after the surgery. So it's our role that as a team, we take care of these points, and proper program has to be conducted, proper accessibility to this program has been to be provided. Thank you for this.
Thank you so much, sir. Now we would request our panelists.
Has highlighted all the relevant points regarding our day-to-day practice. Like once patient comes to us, what happens to them? But cardiac rehabilitation, what I have seen in my career, that there is some lacking is always there. Like patient comes from pre-op, from OPD, so we have to counsel them from OPD. There are many reports also, or even it comes in a guideline of ERAS, like enhanced recovery after surgery, that pre-surgery rehabilitation is also important. Though it is not affected in the mortality, but still the ICU stay, ventilative parameters does affected. So I think in our setup also we should think beyond, like from pre-op. Like what is our practice is generally after surgery we are referring them to cardiac rehab. Pre-surgery we are not referring them very frequently. So I think we have started this approach also, that patient pre-operatively refer to them, and you start from them, so start from beginning. So I think that whatever the lack of motivation program might get improved. For second is like if the patient is stable, then most of the cardiac rehabilitation is going on easily. But sometimes what happens that in cardiac surgery, some patients require more ICU care. Like if he stays in ICU for more than 1 month, then we have seen that cardiac rehabilitation is okay, but his muscular atrophy is there, he cannot able to stand. This is happening. So what could else we can do to prevent them? I want to ask all experts also here that what else can be given to them so that this thing cannot happen. We can prevent by adding some other exercise to them so that there is no muscular atrophy, or at least if he is bedridden for 1 month, some muscle mass will be there so that after 2 or 3 days or 2 or 3 weeks he can be able to get up. Like in children's we have seen that they can recover, but in adults we are seeing that it takes times. It takes at least 3 to 6 months to get them to back to their normal life. If he stays in ICU for more than 1 month, if it stays ICU for 2 to 3 days, then it's okay. He will be okay within 2 weeks. So what else we can offer them, like if patient stays for more than 1 month in ICU? Ma'am.
Yeah. Good afternoon, everyone. Belated Happy Valentine's Day. Continuing the vibes of Valentine Day. दिल का अपना दिमाग होता है जिसे समझना नामुमकिन होता है. But if you understand that, then cardiac rehab is very easy, right? So, as Dr. Manik sir said very rightly, he has covered almost everything. But then the problem is implementing the practicality. What is the ground scenario? And the main barrier is that the lack of reference, lack of understanding, lack of knowledge, not only in patients and relatives, but among us as healthcare professionals. We have to understand the importance of cardiac rehab, how a rehabilitation can help, and the fellow healthcare professionals also.
So, ma'am, I have few suggestions for that.
Sorry?
Me, Pratik, yes.
Yes, sir.
So, I have few suggestions for that.
Yeah.
But, can you imagine an orthopedic clinic without a physiotherapist? No? Then how can you imagine a cardiac clinic without a physiotherapist?
Yeah, that is what
so
it
lack
is.
Lack of a referral is not it's never a practical problem. See, अगर एक बंदा हाथ नहीं उठा रहा है ताली बजाने के, तो आप हाथ और दूर ले जाओ, ताली तो बजनी है. You go and sit there. अगर patient बोलता है कि I am having muscle weakness और मेरे को pain, the surgeon does not have answer for everything. He expects the answer from surgeon, but the surgeon does not have answer for everything. If you are sitting beside, you can directly talk with the patient. The next time the patient will not come to me, he'll talk to you. Sir, मेरे को pain हो रहा है, क्या करने का? So if you are treating it, he will come to you again. But first time he has to come to you. If he is not coming to you, then referral is never a problem. It's all about the involvement. That's what I feel. So if an orthopedic clinic cannot function without a physiotherapist, a cardiac clinic should have a physiotherapist.
Sir, I have something to add.
Yeah.
If we talk about cardiac rehab, it is now the corrected definition is rather than an interdisciplinary approach, it is the multidisciplinary approach.
Multidisciplinary.
The thing is that the adherence is lacking. And adherence comes when a patient realizes that whatever treatment he is getting is successful. And the definition of success is very subjective. He needs to understand that he is getting improvement in improving his quality of life or the functional status in one way or the other way. As you said, that it's not only a life-saving event nowadays, it is how you lead a life. I mean, it's not only adding years to the life, but adding life to those years, and that is what a rehab does.
So the first time he comes in contact with you, and if he sees the improvement, then he will come again. If you taste it once, you're going to eat it again. It's just like that. So the first taste has to develop over there. He has to taste the rehab. Then only he will crave for it. Then only he will see the benefit of it, and then he'll come again. Automatically he will come again. One more thing. That, see, we have seen that maximum improvement in the transplant patient. See, even if a patient is undergoing stenting or a CABG, the patient is not cachectic. A transplant patient pre-operatively is very cachectic. But you see the involvement of the rehab people in the cardiac transplant. The patient is running around after transplant. He is driving a cycle, he is doing gymming and everything. It's not possible. वो patient का already muscle deconditioning 5-6 साल का हो गया है. Not like a CABG of 5-6 months. कुछ हो रहा है. अब आप उसको बाद में बोलोगे एक्सरसाइज करो, उसको फियर है, बट वो फियर जाता है, एंड द पेशेंट इज वेरी कोऑपरेटिव इन दैट. सो what we feel is that involvement is needed from both the sides, and involvement of
That
the
is
entire
what's the multidisciplinary approach.
Yeah,
so,
so
not two sides, there are many sides which needs to be
and
involved.
the patient also, and the family also, and the entire society also. See, हम लोग बोलते हैं कि in our society not much of exercise is there. It has to be a norm. You go to Australia, they have a party where they go and do cycling for 50 kilometers. हमारा पार्टी होता है लापिनोज में होता है या तो ऑनेस्ट में होता है. So our family gatherings also like that. So overall the society is not aware of an exercise. So a person who doesn't know the benefit of exercise pre-operatively or in a normal life is not going to accept the benefit of exercise even the post surgery. और हम लोग क्या ज़्यादातर ओल्ड एज जो होता है वो बोलेंगे कि अरे इसका तो सर्जरी हो जाएगा, ज़्यादातर क्या इसको तो टीवी देख के सीरियल ही देखना है ना बैठ के.
The approach needs to be changed.
हाँ, तो approach has to be changed. So the society also, from the hospital, from the physician, surgeon, from the rehab, everywhere. So we know the multidisciplinary डिपार्टमेंट या इन्वॉल्वमेंट है, बट मल्टीडिसिप्लिनरी जो अप्रोच है वो एक कॉमन पेज पे नहीं आ पा रहा है. सो वो आएगा, डेफिनेटली विल कम. आज नहीं तो कल आएगा, बट द अर्लियर इट कम्स इट विल बेनिफिट द सोसाइटी एट लार्ज.
As director sir rightly said that family, it should work like a family, that ownership of the patient is needed. मेरा patient है ऐसा लगना चाहिए हर किसी को जो टीम में इन्वॉल्व है.
तो वो लैक ऑफ रेफरल वाला टर्म भी नहीं आएगा. रेफर कहाँ, पेशेंट उसका थोड़ी है, पेशेंट आपका ही है, आप जाके पकड़ लो. So that's it. Again, I told you, many a times the rehab person comes, he doesn't know the patient is getting discharged or he's already being discharged. Yeah, that's what. See, so again, I'm telling you, if the patient is your own, you go and there. Referral का तो सवाल ही नहीं है. It's your patient, you go there. अगर नहीं मिलता है तो 10 बार पूछ लो. समझो. Yeah, they are doing this.
So as Sir said, we should actually start pre-operatively and from admission. And what happens is, as she said, it was there. The ownership should be from the whole team. It should not be a cardiac surgeon ka patient hai ya it's not a cardiologist. It's the patient of the hospital, and everybody is an integral part of the hospital, and that patient is ours. It is not someone. It's not an individual's patient. You know, probably if we look at it from that point of view,
when we have ownership, we tend to give the best.
We tend to give the best. I mean, I think that issue would get really solved.
Finally, the success is how a patient is benefited, right, sir? Thank you.
That is our outcome and that is our success.
Thank you.
Thank you.
Anyone has any questions, any comments?
Second point mine was that if the patient stays ICU for more, obviously we cannot start cardiac rehabilitation. So what kind of approach should be given to that kind of patient? Because as you know that it is in 1 month there will be ICU, so he will be hemodynamically for initial 2 to 3 weeks he will be unstable, on dialysis or something. Then he get rid of all the things and now he becomes a bedridden. So what kind of approach in them?
Probably during CABG or in these what do you call angioplasty, occasionally this 1 month episode happens. But as a sorry. As yeah. But as I mean, Sweetie ma'am is there, I'm there. I mean, I've seen her, she must have also seen patients who have been months together on the ventilator. Say for example, neurosurgery. हम तो मान के 2-3 महीने कोमा के बाद patient comes out, and we have to work. The whole thing has to be worked. I mean, just because someone's had a coronary event or cardiac surgery does not mean that his limbs are not taken care of. You know, chest bhi dekh rahe hum, limb bhi dekhna hai. We'll have to say for example, critical care neuropathy is very common because most of these patients are going to be going into that, probably the diabetics, and say all this physiotherapists dekhte hai. Critical care therapy is a totally, it's a different approach. Yeah, there we can't have cardiac rehab. No. Yeah, that has to be, No, we need to take care of the whole muscle mass maintenance and all that. Even at times you might even require as simple things as electrical stimulation. There is new development coming in this restricted blood flow therapy and all. I think we should think about all those things even in the critical care. There are a lot of things which are being done in the ICU. We use resistant bands in the ICU for strengthening. We use leg cuffs to strengthen the early mobilization techniques in the ICU. We recently had a patient who was on ECMO. We mobilized him even with a 5 HB or something. The patient on ECMO was mobilized, walked. So, hota hai. We're trying the best, sir.
I have a question directed to Dr. Pratik. We discussed in detail about what are the things expected from a cardiac rehab perspective and the gap between what is happening right now. And a lot of focus was on lack of referral, lack of accessibility.
No, not a focus. Just the word came. So I was like, let's remove that word. That's what
Okay,
that word is not
let's
needed.
remove that word for an instance. But again, the first contact practitioner in case of any cardiac condition is not going to be a physical therapist for sure. Secondly, for a patient to go to a physical therapist, there is always a cost factor. And we being a
covered that thing, but see, what I'm saying is that even there are many of the things that we are using, we know that they are very costly, we don't know, but we know the benefits of that. Here we don't know, the patient doesn't know the benefit only. So once the patient knows the benefit, he will start practicing it. And see, it's hardly a matter of 2 to 3 weeks. My father himself had a cardiac surgery 2 years back. He did his rehab, initial, even I was dealing with the psychological barriers. He was not depressed, he was not feeling good for 1 month and all. But that once that initial 1 month and 1.5 month of motivation and hardly a drop of rehab, and he was again back to routine. But that motivation part, that everything, because if I was at home, I was able to do that. When the patient is there, no one has, everyone has that support at home. So it's only that much part that we need. Even in our department or in our in our rehab department, they do on that thing online basis also. The patient doesn't have to come over here. So what I'm saying is there are many factors. Everywhere there's not such a big rehab department, or everywhere there is no online counseling or online motivation or online exercise program, or what I'm saying. Yes, we need to take care of everything, and yes, every aspect has to be taken care of, but it has to start from somewhere. That's what I'm saying.
My question being, what you said works for the privileged class. But there are again a lot of people for whom accessibility would improve by improving the coverage from insurance companies and all. So from a standpoint of as being important stakeholders as a healthcare team, what can we do to influence the policy making changes that would improve the accessibility?
Okay, so I rather make every rehab center like UNMICRC at every district and include them in Ayushman Bharat, which is not needed at all right now. UNMICRC does it very well. So, and see, 80% of people that we cater over here are from a very low privilege society. They are not from a high privilege society. Hardly 20% of the affluent people that the UNMICRC is catering to. But UNMICRC is doing better rehab than most of the corporates in Gujarat. So, it's not about privilege. It's not about socioeconomic. It's not about facilities. Facilities is there, but still, they are overcoming that part also. A patient is in Modasa or is in Rajkot and he's being done a rehab on online basis. It's all about just one thing, involvement from both the sides, from all the sides.
Thank you.
More importantly, the understanding.
Yes, everything. Involvement तभी आएगा ना जब समझ में आएगा. तभी आएगा.
Thank you so much.
Thank you.
We would like to request
participation in physical activity is attitude. So I want to put a word CPR, means communication, counseling, physical activity, and robustness is important. Like we need to use the technology. We have to catch them. Like once the patient has came to you, then you call them up, and then what are you doing right now? That is only the solution. See, we cannot reach to the global scenario and whatever is there. We are facing since so many years. So we have to change ourselves, or we have to modulate ourselves. Whatever patient you see, call them up. Like what physical activity they are doing. That is what my input is. Thank you.
Thank you so much. We would like to request Dr. Tejas Naik sir, Senior Cardiac Physiotherapist, to felicitate Dr. Pratik Manik sir. Thank you. We would like to request Dr. Devang Barot, Senior Cardiac Physiotherapist, to felicitate Dr. Karthik Patel sir and Dr. Sweetie Shah ma'am.
Thank you, sir. Thank you, ma'am. Please take your seats. We will proceed further. Okay, so proceeding further, let's welcome our next speaker, Dr. Vishal Sharma, sir, Associate Professor in Cardiology, UN Mehta Institute, who will be presenting on the topic From Symptoms to Solution, utilizing CPET to unveil the exercise intolerance in cardiac patient. Sir holds a vast experience in the field of cardiology and cardiac procedures. He is dedicated and compassionate with keen interest in the heart failure and cardiopulmonary exercise testing. We would like to welcome our esteemed panelist on the dais, Dr. Harda Shah ma'am, Senior Lecturer and PG Guide at Physiotherapy Department, IKDRC, Institute of Transplant Sciences. She has validated and published exercise manuals for kidney transplant and recipients. We would also welcome our second panelist, Dr. Mihir Mehta sir, Assistant Professor in Physiotherapy, UN Mehta Institute. He has a dedicated experience to the healthcare sector, specializing as a cardiopulmonary physiotherapist in leading hospital.
So thank you. So respected all dignitaries, seniors, my colleagues. It is really a honor to be speaking here in front of such an energetic young crowd and senior professionals from physiotherapy. And the last discussion was so interactive, and the crowd was really participating very well. So this was really overwhelming for me, because what we have seen in CMEs and conferences is a one-sided didactic lectures, but here the crowd is really energetic. The other part, I being a cardiologist, I have been trained in a way in which we believe that cardiology is a very non-invasive or minimally invasive procedure, and the patients do get fine very early, which is not true. And staying here in UN Mehta, I have realized the importance of physiotherapy, not only for the patients but myself. Being working here, I have had backaches and foot aches, and I have seen how good physiotherapy really helps a patient out. So my role, I believe, is to sensitize more and more of my colleagues, seniors and juniors about the role of physiotherapy, not only in patients who have undergone surgery, but in patients who have undergone any cardiac procedure for that matter. Because this cardiac rehab part is really missed by patients who undergo interventional procedures by a cardiologist. And with such good team at UN Mehta, it's really at loss of patients to miss this opportunity. Well, my talk is not on rehab though. My talk is on cardiopulmonary exercise testing, which again is a beautiful modality. And when this came in our institute, I was a little skeptical, because this is not much used throughout India. But when I saw this and I saw its uses, the way it works, and I had the luxury to use it by myself, then I realized how easy it is, and how non-invasively you can detect, diagnose certain conditions, and in fact prognosticate them, and also it would help a patient in rehab. So basically it is something, they are simple. I would be talking more clinically about it rather than the technical terms. So basically what we understand from cardiopulmonary exercise test is it decides how much volume of oxygen do you take, how much is the volume of carbon dioxide produced in your body, and how you are going to clear it within physiological limits of heart rate and blood pressure. There are several charts plotted, but simply it's the way the oxygen uptake and the carbon dioxide clearance with the help of the cardiac output you are going to manage. That is what is interpreted in cardiopulmonary exercise test. And this simple logic and simple interpretation of the chart can help you diagnose certain conditions which otherwise would require invasive procedure. So exercise intolerance, it's a hallmark of all chronic diseases like diabetes, stroke, any coronary artery disease, heart failure, pulmonary disorders, and in fact neuromuscular disorders as well. Even in healthy individuals, if you have this limited exercise tolerance, then it is linked to the patient having high morbidity and mortality in terms of having any event in the future. So basically it is nothing but the reduced oxygen uptake. It is the handling of oxygen and carbon dioxide and the metabolism which is assessed in patients who are undergoing cardiopulmonary exercise testing. So this is a diagnostic tool to assess the metabolic function and the handling of oxygen and carbon dioxide in any patient. It detects cardiac conditions, pulmonary conditions, as well as neuromuscular conditions, and using simple parameters like the ECG, the heart rate, as I said, the oxygen uptake and the carbon dioxide output. So simple parameters, the blood pressure, the heart rate, you can measure the oxygen uptake and the carbon dioxide output, and just comparing these parameters you can come to a conclusion which is fairly comparable to MRI and PET scans in terms of diagnosing and prognosticating patients. So as I just discussed, it is quite a user-friendly test, simple things to be assessed, and in terms of sensitivity and specificity, it is quite matchable to standard tests. In diagnosis coronary artery disease, in prognosticating patient with heart failure, in coming to a diagnosis in patients having dyspnea, in patients who have coronary artery disease, you can prognosticate them when they come on follow-up. Heart failure patients, again, you can prognosticate them, you can chalk out the exercise plan, and for athletes you can determine their aerobic capacity and their performance capacity. As I said, compared to the standard tests which involve like cardiac MRI or SPECT or PET scan, the sensitivity and specificity of a cardiopulmonary exercise test done properly matches very close. So this is really means even when I did the test, when I followed up patients, I realized that is really true. Although the numbers might be little high, but yes, it closely matches the findings which we get from cardiac MR and SPECT scan. And we at UNMICRC have this luxury to have both cardiac MRI as well as SPECT as well as CPET. So we have patients in which we have related all the three, and it is really astonishing to find that CPET, being so simple a test, yet matches the findings of a cardiac MR. That is really great. So the things which we actually see in patients who are undergoing CPET. So this is a simple thing, although the terminologies might seem complex, but clinically it's very simple. It is the volume of oxygen uptake we are trying to find out, and what is the peak level of it, what is the maximum level of it. This is the simple thing you have to find out. So when a patient undergoes cardiopulmonary exercise testing, he is undergoing a TMT, and you are assessing how much is the total volume of oxygen he is going to get during that test, how much he can extract well and use it for its metabolism, and finally clear the carbon dioxide well within a limited cardiac output he has. So there are only three parameters: oxygen, carbon dioxide, and cardiac output. These three parameters you have to just mix and match, and you will realize where the problem is. So if the oxygen uptake is less, so your maximum oxygen uptake is less or your peak uptake is less, you are dealing with a condition which might be cardiac or pulmonary. But if you have corroborative evidences of cardiac problems, then it is certainly you are dealing with a cardiac problem if the patient's oxygen uptake and utilization is less. Then we have this anaerobic threshold. Anaerobic threshold is nothing but what is your oxygen uptake at the level of, say, 50% of the VO2 max you are going to achieve. So if at that point you have improper oxygen uptake, it's you are starting the anaerobic metabolism at a very early stage, and that again carries a poor prognosis. Means your handling of oxygen and carbon dioxide is not proper. That might be due to improper cardiac output, or that might be due to some pulmonary or muscular disorder. Then oxygen pulse, a simple parameter. It is the oxygen uptake by a patient divided by his heart rate. So let me tell you, this is a simple thing. Your cardiac output is fixed by your stroke volume and heart rate. So whenever you exercise, your stroke volume increases, so does your heart rate. Now if a heart is good, he would have more stroke volume and less of heart rate. Okay, if your heart is healthy, makes sense. But if your heart is unhealthy, you will have lower stroke volume, and to compensate for the stroke volume, you will have a more heart rate. So simply, if you have any oxygen uptake at any level and you divide it by the heart rate, you get a parameter which is called the oxygen pulse. So simply, if you have more of tachycardia, that means you are unhealthy or you are deconditioned, or you might have some cardiac disorder limiting your stroke volume, and ultimately that amounts to diagnosing the cardiac pulmonary or the muscular disorder. So the term might sound oxygen pulse, but it's very simple. It is the heart, how the heart rate response is to your exercise during the CPET. Then we have this ratio of, again, oxygen uptake and the work rate. Work rate is nothing but we have defined like METs, we have the defined for every oxygen uptake we have this defined physiological limits. So I understand it's almost 8 to 10 ml per minute per watt of work that you do. That is the minimum amount, or the normal range, 8 to 12. If you have a lower, so for a defined work, a physiologically fit person would have defined oxygen uptake, and if that oxygen uptake is not well, again, you are dealing with condition which might be because of decreased cardiac output or some pulmonary condition or deconditioning. Then we have this heart rate, work rate slope. Again, as I told you, only 3 parameters. Cardiac output is nothing but stroke volume and heart rate. So if something is going wrong with the stroke volume, the heart rate response has to be abnormal, and you can just plot in the chart and see that the patient is suffering from a cardiopulmonary condition. Then we have this ventilation by volume of carbon dioxide slope. So again, the terminology seems to be very complex, that VE by VCO2 is nothing, very simple, that the volume of carbon dioxide produced, how much is the minute ventilation that is required to clear that carbon dioxide. That's so simple. So if a person is requiring more of ventilation to clear a particular amount of carbon dioxide, he is in trouble. That makes sense. So from this test, if the slope is abnormal, you are clear the patient is not clearing the carbon dioxide properly. And that might be due to a pulmonary condition or cardiac condition, which you need to have corroborative evidence of. Again, chronotropic responses and heart rate recovery. As I said, abnormal heart rates during any testing indicates poor cardiac function. So in which patients and how can we use CPET? So coronary artery disease, I can tell you treadmill test might be a good test, but there are cases which I have seen in which the TMT was borderline. The patient then went to do a stress cardiac MRI, in which he had this ischemia. We got the CPET done, and in the CPET he had this abnormal heart rate response, and he had also abnormal anaerobic threshold. So the reduction in the cardiac output and stroke volume under stress, that is beautifully detected by CPET. If a CPET is properly performed, you will realize that the patient is not having proper increase in cardiac output, and by that simple thing, even if the TMT is borderline, the ECG changes are not much, you can make a diagnosis of patient having some sort of ischemic heart disease. So as I said, it can identify mechanical dysfunction before ECG changes or symptom appear. So before TMT, if the CPET is done properly, if you think the patient's symptoms are typical, you can subject him to CPET, and you will realize that you have done a good test. And this matches stress MRI, so that's fair enough. So these are the parameters. As I said, if the patient is having some cardiac disease, he would have abnormal cardiac output and stroke volume. So what will happen is, because the cardiac output is not proper, the blood going to the lungs is not proper, and the blood coming back from the lungs is not proper. So you'll have a lower oxygen uptake, you have inefficient clearing of carbon dioxide, the oxygen pulse or the heart rate at which you achieve the oxygen uptake is abnormal, the end tidal carbon dioxide, that is again abnormal because the CO2 is not clear as your cardiac output was low, the heart rate recovery, which is very sensitive both for treadmill and CPET. The heart rate recovery is very sensitive. Your heart rate is not recovering well, either you have some coronary artery disease or you have autonomic dysfunction. And finally, the exercise time. So if the exercise time is less than 8 minutes, or you can say less than 7 minutes, you can say the patient is suffering from some sort of cardiopulmonary disorders. Cardiomyopathies. Again, cardiomyopathies would have some abnormality of cardiac output of stroke volume. Very simple. Again, oxygen uptake would be abnormal. The amount of blood circulating through the lung would be abnormal. VO2 max and the peaks would be abnormal, because these patients usually compensate for the as such VO2 and other VO2 parameters like the VO2 with the work rate, but the peak of the oxygen uptake, the peak and the max, that is usually abnormal because they cannot generate a stroke volume which is equivalent to the normal subjects. Again, same for the heart failure patients. They might compensate for normal oxygen uptake but they won't be able to compensate to achieve a peak good oxygen uptake or the maximum oxygen uptake. Similarly, other ratios, as I said, since their cardiac output is limited, they won't be able to match oxygen uptake for the required work. So for a required amount of work, they would be using less amount of oxygen. The oxygen uptake at that level would be less. The clearance of carbon dioxide would be abnormal. And if you set ventilatory thresholds, at that time their oxygen uptake would be abnormal. There are some complex terms like the exercise oscillatory ventilation, but I think that doesn't make sense here. Different parameters others can be used, but these simple parameters would also guide you towards the diagnosis and prognosis of these patients. In fact, we have been using CPET. There are heart failure patients are numerous, the population increasing day by day, and hence to stratify them so as to select them for transplant is an important thing a physician has to do. And for this, we have been using CPET, yes, because you need to stratify the patients so as who warrant early transplants and who can be managed on medicines. Most of the patients would have some complaints or the other, but CPET is a very simple test so as to risk stratify them so that they can be subjected. So a decreased VO2 max, the maximum amount of oxygen uptake, and an abnormal CO2 clearance as shown by the ventilation VCO2 slope that indicates that the patient should be subjected to early transplant. Again, cardiac rehab, already much discussed, but this is how CPET can help. So what we can do is we can have ventilatory thresholds. If you are performing the CPET, just properly plotting the VO2 against the work, you can have ventilatory thresholds marked and decide how the patient, where the patient can be put in rehab. You want him to, so you can have ventilatory threshold 1 and 2 means different, the first third, the middle third and the last third, and depending upon the capacity of the patient, how VO2 max he achieves, how clearly he clears carbon dioxide well, you can decide the rehab program for the patient, gradually upscale it from ventilatory threshold 1 to say 2. So depending upon how much maximum oxygen uptake he is having, what is the peak oxygen uptake he is having, and how well he is clearing the carbon dioxide by the VVCO2 slope, I think you can decide how much threshold should be kept during the rehab. So this is the Nile panel plot. Seems very complex, multiple dots plotted, multiple lines drawn. Any naive physiotherapist seeing it would feel that, oh, what should we interpret from this? But as I said, the things is very simple. You can make it complex by plotting it n number of ways. This is 9 panel plot. You can plot in 19 panel or even do a 50 panel plot. But that doesn't make sense. The things that make sense is you must be knowing that what are you going to assess. You are going to assess the oxygen uptake, you are going to assess the carbon dioxide clearance, you are going to assess heart rate, you are going to assess the blood pressure, and these are the simple things that you are going to assess. By that you can assess the cardiac output, you can assess the stroke volume, you can assess the pulmonary function. So these are the simple things you are going to assess. You can plot n number of charts, but by just mixing these components you can come to a fair enough diagnosis. So these are the various patterns that we see in patients who have cardiovascular, pulmonary vascular, simple pulmonary disorders, or finally the patients who are deconditioned. So the important thing I would like to say is that most of the parameters overlap. So as I said, just getting a Nile panel plot, or just getting the fact that the patient has a low oxygen uptake, or the peak oxygen uptake is low, or the maximum oxygen uptake doesn't make sense. There has to be corroborative evidences so as to classify a patient under a particular disease subset. For cardiac patients, I believe it's the heart rate response, the ECG changes, the blood pressure response that really makes sense, and the symptoms of the patient. For pulmonary patients, it is the oxygen uptake, the carbon dioxide, improper carbon dioxide clearance, that is the VVCO2 slope, that matters work, and the VO2 work rate ratio. So at what work the patient wasn't able to get the maximum oxygen level which a normal patient should have been. For only pulmonary patients, it's the breathing reserve, which we also get during CPET, is more important. For deconditioned patients, they usually have a normal breathing reserve, but abnormal oxygen uptake of peak and max and at anaerobic threshold. So just to summarize, CPET is a powerful tool, and it is not used properly. Even at our institutes, we need more of sensitization, and actually it's our part to do that, and I'll be trying more and more from my side. But yes, it is very nice. I have seen patients, I have compared them using MRI, and I have seen that the comparability is very nice. in terms of facts. It's so non-invasive and easy to do. It plays a crucial role not only in detection, it also treatment planning. I tell you rehab also. So if you have the values with you, you can just manage the patient in putting them in a proper rehab schedule. There are, as I said, only 3 parameters are important: oxygen uptake, carbon dioxide clearance, and what is your heart rate, blood pressure, and cardiac output. Just mixing and matching them, you can come to a fair enough diagnosis of what the patient is suffering from. It identifies not only ischemia, it identifies reduced stroke volume as well, autonomic dysfunction, and even deconditioning. As we said, we in our institute had been using it predominantly for heart transplant, but as more and more number of patients can benefit from this simple test. So thank you all for your patient hearing. I'll be really glad to answer any questions. Thank you.
Thank you so much, sir. Now we would request our panelists to proceed to the discussion session.
Hello. Thank you, sir. It was a very nice presentation, and you have covered all the aspects like cardiopulmonary, cardiology, and pulmonary only, and of course deconditioning. So it was a very nice presentation. So I would like to ask, this is a new way for a physiotherapist to interact in the cardiopulmonary field as a a team of which include also cardiologists, and can be helpful to the professionals for diagnostic as well as giving them some ideas for prognostic as a prognostic tool.
So I truly agree. First of all, for physiotherapists, yes, it's very nice test, and if performed properly and if you are doing it right again and again, you will have n number of references coming up to you. As you said, referrals, so referrals will be coming up to you, because if this test is performed properly and you give a proper answer to the clinician that okay, this is the problem you're suffering from, it saves lot of time, lot of energy, lot of money. And this is so I as a cardiologist always believe that no matter what the corneal lesion be, it's the physiological response that is matter. So a patient might be having triple vessel disease, but that triple vessel disease is not troubling the patient, so it doesn't matter anyways. So this is a physiological test. It's actually tests the response to those coronary artery disease. So one patient might be having coronary artery disease, not getting disturbed. Why touch that disease? He doesn't require a CABG or a stenting as well. So that is the beauty of it. All other tests which we have, apart from the MRI and the SPECT, are anatomical tests, which as was discussed by Dr. Pratik, doesn't impact the quality of life. So the patient might be living fairly enough with those anatomy, but still people get referred for CABG or stenting. So this is a beautiful test if performed properly, repeatedly, and you have similar results again and again. This would be a beautiful way to interact with the cardiologist, come in contact with them, and have referrals, as you said.
Hello. Sir, it is an amazing presentation, and for us there was a lot to learn. If I would say that the cardiopulmonary exercise testing, it's more of laboratory based testing that we have most of the time learned. It requires a lot of setup, monitoring, but it is a very robust test to evaluate a whole oxygen pathways. Like if you put aside a cardiac elements just for a moment, then extra cardiac causes of exercise limitation can be very well be explained. And then yes, I definitely agree. If you come to know about the ventilatory threshold, anaerobic threshold, so we used to term, we are very used to term that low intensity of exercise, moderate intensity of exercise, and high intensity. So ventilatory threshold is a marking point where below ventilatory threshold your low intensity stays. Between two ventilatory VT1 and VT2, your moderate intensity stays. So even you do not exercise the patient at VT1, you are not going to end up with any results. So you have to work with particular intensity. That is one valid point. It was very wonderful. And another thing is, sir, that we need to learn that, see, it is
non-invasive test rather, but there are chances of untoward effect during the test is there. So what is your input for that as a physiotherapist? If they are working in a laboratory based CPET examination, what care should as a physiotherapist should take?
Yes, see, it carries the same risk as a treadmill test. Won't carry an extra risk, but the patients you would be catering to would be of higher risk. So treadmill test is not done for heart failure patients. Okay, treadmill test is not done for pulmonary patients. So this is a difference between a treadmill test and cardiopulmonary exercise test. So I think it won't be a good idea to start a physiotherapy setup alone for cardiopulmonary exercise test. It doesn't make sense. Because you need to have backup, because the population you are going to cater to is completely different. Pre-heart transplant patients, post-heart transplant patients, assessing their ventilatory thresholds. You have those heart failure patients. I think this should not be attempted as a standalone capacity. This could be dangerous. Yeah.
A lot of CPET tests are being performed right now and for sports medicine, like for exercise performance. Like at a local level, musculoskeletal system, lactate and all, how at what rate they are being washed up. The forum is open for question on floor. Do anyone have any question?
Can you share your experience, like a real case scenario, that how any CPET test was done and the results of that, how you correlated that the surgery has to be planned, like CABG has to be done immediately or like post, like how planning was done and how correlation was made?
So as I said, there was a case in which the patient had this complaints of, some sort of atypical chest pain, you can call. He got a treadmill test done. The ECG changes were insignificant, very significant, and although the heart rate recovery was little less, but it was okay. But he used to come again back to OPD saying he has this ongoing chest pain. Now the question arises, what do? You can directly subject him to an angiogram, get some blockages, fix them up, and again the patient ends up in having chest pain. This is what the usual scenario is. Or subject to him a proper physiological test, which gives you the answer that okay, this whatever symptom he is having is affecting his life physiologically, and if corrected would really improve quality of life. So that patient was subjected to CPET. He had this abnormal oxygen uptake response, and his VVCO2 slope was also abnormal. The ECG changes were similar, and the heart rate recovery was abnormal. So from that we made a point, okay, we'll do an angiogram. We went in with the angiogram. He had this lesion in LAD which was somewhere around 80%. We stented it, and then the patient was happy. So the point is, there are n number of patients who have this chest pain, which is non-cardiac chest pain, but because of the availability of cardiologists and surgeons nowadays, they get tested in a way which is anatomical, and get treated in a way and end up having the same symptom after their treatment. So this can be prevented beautifully by physiological test, which can be any physiological. We have MRI also. MRI also tests us in the same way. SPECT also. We have CPET also. So you can use any of the modality. The CPET is fair enough, does well, but it requires a little practice, repetition, and protocols. So that is required.
Every criteria seen, or only like main 3-4, like V by
As I
VCO2?
said, you need to have the basic understanding.
Okay.
You can plot 20 plots, 50 plots, anything you can plot against anything. But the thing is, you understand, okay, if these 4 parameters are there, how do I assess them in a particular patient? So that is also to be understood. So parameters to be taken into account with corroborative evidences. Okay, this patient is having pulmonary problem. Then if you think, okay, this VO2 response is because of cardiac, that won't make sense. So if the patient is having chest pain, you think, okay, this VO2 response is probably due to the pulmonary condition, doesn't make sense. So taking the clinical picture into account, if you set the 4 parameters, you mostly reach to a fair diagnosis.
Thank you, sir.
Hello. And adding to that, we also have one case where I think V by VCO2 was abnormal, and 80 was not achieved post transplantation. And then I think we have consulted with the sir and Manek sir, and we there is a team. I think in our team we are 3 physiotherapists. One is sir, and I think Pratik Manek sir is also there. So we have discussed it with them, and ultimately after studying that the whole the parameters, we come to a conclusion that this is only a deconditioning, and we just kept the patient into transplant rehabilitation, that is tele rehabilitation, and we have got the wonderful result after 6 months. So it is something like that. You cannot venture alone. You have to have a team when you go for the CPET.
CPET for sports medicine you can venture alone, but for cardiac things
Cardiac
you
it
need
is
to
not
have a
advisable.
team. Otherwise things won't, means you won't end up doing right diagnosis, and ultimately no one will then refer or connect with you. You need to have that touch with the cardiologist, sit together, and then you can come to a fair enough diagnosis.
Good afternoon, sir. Thank you for the presentation. We learned the parameters well. The question is, you said like sometimes TMT shows the borderline changes, but only in the CPET we get the detailed information. And in the first slide you have already written that the healthy person, sometimes they are with a good exercise tolerance, even they are prone to go for the mortality rate. Based on this, I would like to ask that if the person is having mild symptoms, and then clinically we just, you'll be assessing, but on what basis you will just post them for the CPET?
See, if the TVMT is showing, I usually prefer this if any patient comes to me with chest pain with no resting changes in echo or ECG, then I usually subject them to a treadmill test. If the treadmill is positive, it's done. It's physiologically significant. You go for an angiogram, then you get a plasty or a CABG done. Now, if the TMT is not, strongly positive, sometimes the TMT shows, there are artifacts also. There are because it has its own sensitivity and specificity of 75-80%. So it has its limitation. So when that limitation comes, that is the time when you can use CPET, and there are n number of patients with coming with up that limitation. But most of the time they end up getting an angiogram, and what happens is you have some blockages. If you do an angiogram in the entire this auditorium, you'll have n number of blockages. So they get treated for a wrong thing, and ultimately end up having the same symptoms. So it is those patients, who are undiagnosed. Means clinically, if you are not confident that he is having gonorrhea, you should not subject him to an angiogram, just because you think that it is.
That could be the blocks.
So this is when you are confident that this is a lesion which is physiologically affecting the patient in terms of ischemia or reducing the cardiac output, then that is the patient that should be subjected to angiogram. Otherwise, you will end up having result which you don't know what to do with. You have this triple vessel, which artery to open, which stent to put, or refer to a surgeon for CABG, and then he comes after CABG, comes back with pain, which is terminal pain now, the wound pain, and this cycle goes on and on. So you'll end up with this, the pain and the surgery is pain, and the patient just has pain.
Thank you, sir.
Thank.
I have one question to ask, sir. There are many protocols like treadmill versus cycle ergometer protocol, REM protocol versus step protocol. And do your protocol differ between the conditions, or do rely on certain protocols? Like for stress testing, we rely on Bruce protocol. For CPET, which protocol do you follow? And for various conditions, do that differ?
We have here a treadmill test, but I think for heart failure patients, cycle ergometry is a little better, I would say, because these heart failure patients, if you see the complete setup of CPET, it's quite overwhelming. So I really doubt how the heart failure patients and the patients with real angina would be tolerating that thing. So they should have cycle ergometry according to me, ideally, because they are really functionally decapacitated, and if anyone has the opportunity to wear that mask, he can wear one, and stand on that treadmill, he will realize how tough it is. I have done it myself. It's very tough. It's so overwhelming for a normal person. So I don't know how heart failure patient must be doing it, but they require cycle ergometry for ischemia testing and basic testing. This treadmill test with Bruce protocol is fair enough. Modified protocols for heart failure patient, but the treadmill itself with those gadgets is very overwhelming. So I don't think changing the protocol of the treadmill would benefit really, but it is how it is done. But I believe cycle ergometry is better.
Thank you.
Thank you so much, sir, for sharing your knowledge. During your presentation, even during discussion with the panelists, you are using a word, if the test is done properly. So properly means the exercise intensity, what ma'am has discussed, the parameters according to which we plot the graph. You said we can select n numbers of parameters. So is there anything else on which we can say now the test is done properly?
Properly, actually, I meant to say that it is done meticulously. You see to it that the mask is properly applied. You know, there is no air leak.
Okay.
The casualness is not allowed in this test. It is as good as doing an angiogram. So, I mean, this is for the younger generation, actually. Okay, this is not a casual test. Don't take it as a treadmill test. Okay, the patient is walking, you are looking here and there. It's not that test. So that's why I was emphasizing the fact that do it properly, because the interpretation is important, and if anything is missed, you will end up giving a wrong result, and then no one, of course, if things are not matching, people won't send it to you to assess.
So properly means subject to subject it may
You
vary.
should be, and you should be doing it always with the patient, monitoring their heart rate response with every escalation, monitoring the charts at the same time, and are they matching? Means if the heart rate is not increasing but the oxygen uptake is decreasing, doesn't make sense. So this should not happen. The heart rate should increase proportionately. So you should be monitoring it very carefully. Should not be done casually. This is the only message I wanted to say. Should not be done casually. Otherwise, nothing specific. Should not be done casually.
Okay, thank you.
Termination criteria also for CPET. Then there is one parameter like RER ratio that can be seen while doing the exercise, so that if patient's effort is optimal or not, you can access it. But for that you need actually as a physiotherapist you need a good exercise physiology in detail. You should know the exercise physiology.
Understanding of that physiology should be there.
Yeah.
So that is what we wanted to emphasize.
The proper means.
Okay, thank you, sir.
Thank you so much for this information. Now we would like to request I would like to request Dr. Neha Parmar, the senior physiotherapist, to felicitate our Dr. Vishal Sharma sir. Now we would like to request Dr. Ikta Thakkar to felicitate Dr. Harda Shah ma'am. Now we would request Dr. Kinjal Patel, Senior Cardiac Physiotherapist, to felicitate Dr. Mihir Mehta sir.
Thank you so much. Now, calling upon our last speaker of today's event, Dr. Aisha Mullah ma'am, in charge principal and associate professor in physiotherapy, UN Mehta Institute of Cardiology and Research Center, who will be presenting on the topic Innovative Pathways, the Future of Cardiac Rehabilitation Through Technology Integration. Ma'am is an inspiring educator. She leads us to high quality patient care and promotes continuous education and research activities. We would also like to welcome our respected panelist on the dais, Dr. Sudarshan Nambi, Senior Consultant Physiotherapist. He is a renowned name in the field of cardiopulmonary physiotherapy and is also a part of Advait team of oncology. We would also like to welcome our second panelist, Dr. Anjum Akhtar Sir, Associate Professor and in charge Principal at Mahatma Gandhi Physiotherapy College. Sir has more than 15 years of experience as consultant cardiopulmonary physiotherapist at various leading hospitals of Ahmedabad.
Good afternoon to one and all present over here. Let's see the last topic, which is innovative pathway, the future of cardiac rehabilitation through Institute of Cardiology and Research Center, a 1251 bed cardiac specialty teaching hospital, has established the cardiac rehabilitation phase 2 for enhancing the cardiovascular health and quality of life of patient. The main objective of this to address the gap in systematic and evidence-based exercise prescription. It uses the advanced cardiac risk stratification system so that intensity of monitoring and supervision during rehab can be decided. Also, tailored exercise prescription is done based on the in-depth evaluation of the patient. Real-time vital monitoring ensures the patient's safety during the exercise session, and additionally, integration of advanced technology is done using the wearable frontier devices. Hence, we can say that evidence-based approach and technology integration had led to the enhanced patient safety and optimized outcome in the cardiac rehabilitation. Now, technology integration in the cardiac rehabilitation, of course, it has transformed the landscape of care for the cardiovascular disease patient. Last decade, or I can say that before 15 years, or that multi-para monitors, ergometers, telemetry devices, and mobile apps were used to observe the vitals before, during, and after the rehabilitation. However, of the past 15 years, wearable sensing technology has advanced, allowing the wearable devices to monitor the increased range of physiological as well as behavioral characteristics. Let's see few of the wearable and patches of the advanced technology. I would name here few of them: medical grade adhesive patch, clothing embedded sensors, chest strap, armband, wristband such as Fitbit, bio stickers, and Polar S10. Now, most of them will give you the information about the heart rate variability, ECG monitoring during the rehab as well as the arrhythmia. Fitbit and armband will give the additional information such as physical activity level, sleep quality, and overall health of the patient. Second important thing is the frontier devices. This we can use when we don't have the system of telemetry, but we have the ergometers, and this is mostly useful for the heart failure patients. We generally use the frontier device during our rehab. So what it does is significant, this is of course the significant advancement in the cardiac rehab. What it will give you? It will give you the data of 24/7 ECG monitoring. Even different mode of exercise you can choose in that, whether the patient is doing cycling or treadmill or doing floor-based walking. So during that also you can get the ECG. Real-time vibration alert it will sense on your phone or the desktop when the vitals are going beyond the range. Training load we can see. Most important, it has heart strain. How much is the heart strain during exercise? That also give you number by the number. Breathing rate, heart rate variability, and once the patient complete the exercise session, all the data you will get by the mail, so we can have the record of the patient's monitoring. So the ability to provide the continuous monitoring, high quality data collection, real-time feedback, enhanced patient engagement makes the effective tool for improving the patient's compliance and outcome in the cardiac rehab program. Now, in the era of the artificial intelligence, there are few of the apps and software. We can say that it will help in improving the adherence as well as outcome of the rehab. First one is the Canto Health. It will offers the personalized rehab through the patient data and real-time monitoring using the wearable technology. Second one is the wearable integration. It provides the continuous monitoring and feedback to the patient, so the patient engagement and timely intervention if the vitals or the any other issue arises during the rehab, we can overcome that. And last one is the recap, which stands for the rehabilitation through exercise intervention for the cardiac patient using the artificial intelligence program. This is the software and trial mainly designed for the home-based cardiac rehabilitation. It uses the AI to precisely prescribe the exercise on the weekly basis, which is tailor-made and also updated over the time. Now, while using all this technology, what will get the impact on the cardiac rehabilitation? So first one is better access and participation. Second, it mostly accommodate the patient who have the geographic barriers or the competing priorities. Here on our day-to-day basis, we face the problem that the Ahmedabad patient can approach and come here at the center. But the 80 to 60% of the patient who are from out of Ahmedabad, it is not easy for them to reach at the Ahmedabad center. Even the patients from the Gandhinagar or Kalur or the nearby area cannot come here for the center-based rehabilitation. So for them, if this technology we are using along with the tele-rehabilitation, their access and participation has increased. Second one, adherence means more and more number of the patient have participated and completed the tele-rehabilitation sessions, so improving the adherence. Monitoring, of course, it has improved, and by all over this, as a clinical therapist and as the physiotherapist, we can say that we can improve our decision making for implementing the cardiac rehabilitation. Second most and important branch of technology is the tele-rehabilitation. Of course, it is the branch of the telehealth, which we can use for the consultative, preventive, diagnostic and therapeutic services. Now, how we implement or execute the tele-rehabilitation is important. It has few steps. First one is the program structure. We can implement it through the hybrid model or directly through the tele-rehabilitation. In the hybrid model, the patient first do the few sessions at the center and then enroll in the tele-rehabilitation. Whether in the second part, the patient is directly assessed and enroll for the tele-rehab session. Now, important point here is the patient selection and assessment. It is very important that you once assess the patient at the center, see the report, assess the patient physically, whether the patient is ready to enroll in the rehab. So for that, what all things you have to see? Clinical status, person's circumstances, fine. Factors such as the recent cardiac events, risk stratification, most important, investigation and assessment. Once the patient is ready, you familiarize the patient with the technology of the video conferencing, because here most of the patient we are getting are of the underprivileged. Sometimes they don't know how to use it, and even some caretaker or home member should be present, which will help them in using the teleconference technology. Next is the exercise prescription. So of course the exercise prescription should include the 3 phases of ours, that is warm-up, training phase and the cool-down phase. Generally we made the group of the similar conditions over here for the telecardiac rehabilitation. What you can do is the intensity will not be same for the CABG patient as well as the valvular patient or the heart failure patient or PTCA. So you can make the group of the same people or same patients on the one tele session, and then you can scrutinize or you can do the intensity, plan the intensity according to that. Next is the education and support. Once you have started with the tele-rehabilitation, it is very important that the patient should adhere that, and other guidelines also should follow. So for that, the education and support is provided through the soft copy as well as during the virtual session. And lastly, evaluation of the outcomes. So we can come to know that how much effective your telecardiac rehabilitation is really done. So what we can check is exercise capacity, again cardiovascular risk factors, you have to check it, and patient satisfaction, as how much the patient got the satisfaction after the rehabilitation. So let's see the glimpse of the tele-rehabilitation at our center.
ગુડ મોર્નિંગ બધાને. વોર્મ અપ કરવાનું છે આપણે યુએન મહેતા ઇન્સ્ટિટ્યૂટ ઓફ કાર્ડિયોલોજી એન્ડ રિસર્ચ સેન્ટરમાંથી. ચલો આપણે એક્સરસાઇઝ સ્ટાર્ટ કરીએ છીએ.
Now, after using the technology, after doing the tele-rehabilitation through the video conferencing, we have to see how it is effective for the patient. So for efficacy of telecardiac rehabilitation, we are checking by how much enrollment is there. So last year in year 2024, we can say that 450 patients have enrolled in the tele-rehabilitation and completed the whole rehab program. The physical capacity is improved, which we can see here that 6-minute walk distance and improved by 85 meters average, and VO2 max by 3.98, and MET level improved from 5.12 to 6.98. MET level, it is important to check here. Why? Because that will indirectly indicate how much the activity of the patient has improved. Now here is some data I want to represent of the center-based cardiac rehabilitation. So at the center, usually we enroll the patient before, during and after the rehab. We again And again, check the physical capacity of the patient, patient satisfaction, and patient reported experience measure. So 6-minute walk distance, you can see here that is average improved by 89.43 meter, which is more than the published data of 60 meters. So according to the published data, if the 60-meter difference is there in pre and post, that says that it is clinically significant for the patient. VO2 max estimated improve of 4.3, which is also the more than published data 2.16. And lastly, MET level improve by 1.72, which is near to the published data 2. So we can say that the activities of daily living has also improved and capacity of work. Not only the physical activity, but we also have to see how much the patient has satisfied and how much daily activities is improved. So 24% improvement is seen in the activities of daily living. That is taken by the patient specific functional scale and all. And 96% satisfaction rate is seen in the cardiac rehabilitation. Not only this, but patient reported experience measures say that how much patient satisfied or how is the experience of the center-based cardiac rehabilitation. So here you can see that patient is satisfied with the cleanliness of the center, improve their ability and quality of life. Third one is we have to inform how well the patient is doing. So patient engagement and adherence will improve. And monitoring during the rehabilitation session, behavior of staff, and freedom to choose the therapy and time. So we can say that we have able to achieve the excellence in all the category by this time. And lastly, I would like to end the session by showing one feedback of the patient.
હું કલ્પેશ શુક્લા, મારું ઓપરેશન 15 જૂન 2024ના રોજ ડૉક્ટર ચિરાગભાઈ દોશીના વડપણ હેઠળ છે કરવામાં આવ્યું. ઓપરેશન ખૂબ ક્રિટિકલ હતું અને છતાંય ખૂબ સફળતાપૂર્વક છે ઓપરેશન મારું પાર પાડ્યું. તે માટે ડૉક્ટરોની ટીમનો હું હૃદયપૂર્વક આભાર માનું છું. અને ઓપરેશન પછી મને જ્યારે કહેવામાં આવ્યું કે તમારે છે રિહેબિલિટેશન સેન્ટર ઉપર છે ફિઝિયોથેરેપી છે નિયમિત સમયે છે કરવી જરૂરી છે. અને પહેલે જ દિવસ મારો રિહેબિલિટેશન સેન્ટરનો અનુભવ જો કહું તો એવો છે કે મને કહેવામાં આવ્યું કે ફક્ત 6 રાઉન્ડ મારો અને પહેલો જ રાઉન્ડ મારતા મને એટલો થાક લાગ્યો કે મને થયું કે આમાંથી ને બહાર આવતા તો મને છે મિનિમમ 3 થી 4 મહિના લાગી જશે. પણ અહીંનો સ્ટાફ છે એ ખૂબ જ સરસ પ્રેમાળ અને હૃદયપૂર્વક મને છે એ સાંત્વના આપતો ગયો. અલગ અલગ સાધનો છે અહીંયા ફિઝિયોથેરેપીના છે એ ઉપયોગ કેવી રીતે કરવો સમયે સમય એ રીતે મને છે ફિઝિયોથેરેપી સરસ મજાનું માર્ગદર્શન હેઠળ છે એ કરાવવામાં આવી. અને પરિણામે ફક્ત 15 જ દિવસની અંદર છે મારી હેલ્થમાં એટલો બધો સુધારો થયો કે હું છે મારી ગાડી છે જાતે ડ્રાઈવ કરી ઘરે જઈ શકતો અને ઘરેથી ને છે અહીંયા આવી શકતો. અને એટલો બધો કોન્ફિડન્સ ને આત્મવિશ્વાસ ફક્ત આ ફિઝિયોથેરેપી કરવાથી જ આવ્યો છે મારામાં. અને એના માટે અહીંના હેડ ઓફ ધ ડિપાર્ટમેન્ટ ડૉક્ટર આયેશાબેન મુલ્લા અને તેમની આખી ટીમ એમનો હું ખૂબ આભાર માનું છું. મને અહીંયા બધી જ સંપૂર્ણ સારવાર છે એ મળી ગઈ છે. આજે હું એકદમ તંદુરસ્ત અને સંપૂર્ણ રીતે છે એ નોર્મલ જીવન જીવી રહ્યો છું. એના માટે UN મહેતા હોસ્પિટલનો હું હાર્દિક અભિનંદન કરું છું. ધન્યવાદ.
Thank you so much, ma'am.
Good afternoon, ma'am.
Yes, sir.
Ma'am, it was very nice presentation and
Yeah.
you have included number of things you are doing over here. One thing I would like to ask,
Yeah.
What are the wearable devices do we have over here? What you shown, everything we have over here, and how it is going to be used during the session or?
So generally for the CABG and the valvular post-surgical patient, we use the multipara monitor itself because they do not require the continuous monitoring as such the heart failure patient. But for all the heart failure patient, we are using this frontier devices. What we have, the 1 or 2 devices we have, so we schedule the patient such that we have one device with the one patient. Along with that, whatever the ECG and all rhythm and heart strain it is showing, which we can see on our mobile phone as well as on the desktop. So any changes if we have, so we can stop the exercise during the session or we can modify it according to the patient. So we have this frontier device. Apart from that, we have lots of multipara monitors, we have simple sphygmomanometers, we have one thing I want to add here is we have the electronic health record system over here, which we can say here HMIS. So for every patient, every assessment is entered in that, fed in that. Every vitals before, during and after of each exercise is also fed in that. So at the end of year also, if you want to see how the patient has progressed, so that we'll come to know. And once this exercise with the Frontier device is done, we'll get the mail on the whole ECG and whole the exercise session, how is the response of the patient vitals on our email.
Okay.
Yes,
The
sir.
next question is, ma'am, what is an average duration of single session of patient?
Here we are doing for 40 to 45 minutes. Initially, if patient is debilitated, sometimes we get the patient immediately after 15 days and 20 days and all. And sometimes the patient we get off the 3 months also. If we ask them what you were doing, they were doing nothing, just sitting and resting at home. So initial session of the longer duration, 45 minutes to 1 hour I can say, because they need so much of rest or the break in between the session. Afterwards it goes for 40 to 50 minutes.
And in tele-rehabilitation, if you are,
Yes,
you know, recruiting the patient for tele-rehabilitation,
yeah.
so do you have any specific criteria after how many days patient can enroll for the tele-rehabilitation? Do you have any specific vital monitoring systems or vital monitoring aspects when patient is, you know, doing from apart? So how that works?
Yes. See, it is very important that sir has asked the question that safety of patient is very important when you're implementing the telecardiac rehabilitation. So first of all, the patient has to once come to your center, assesses thoroughly, and then only enroll in the rehabilitation. So for that, we have the risk stratification system here, mild, moderate and severe, mild, moderate and high. We are just including mild and moderate level for right now for tele-rehabilitation. We are not including the high-risk patient. Secondly, whenever they come here, we show the exercises once at the center. We teach them how to take the vitals. Most of the patient have the pulse oximeter and all. So we ask them to take the vitals along with that. If not, simply we teach how to take the pulse and all. Not only that is enough, sir. We have the telemedicine department here in our hospital. So if anything happens, we explain the patient on the first visit itself that if anything happens to you, do you reach to the nearest hospital or you call the telemedicine department over here. Till now, thank God, fortunately, we don't have any such cases of the uncertainties or you can say high risk during the rehabilitation. But everything you have to explain once on the first session. Even you have to take the consent that the patient is ready to enroll in the tele-rehabilitation. Then only you have to start.
And do we have a specific sessions of tele-rehabilitation weekly
yes.
or on,
Yes,
on
sir,
what
yes.
basis you are deciding
Yeah,
that?
generally we have 3 to 4 batches, sir. Initially we have started with the CABG patients only because we thought that it is the safe population and low risk patient only were enrolled. But once it was done, we have a separate batch now for the CABG patient, 2 batches. Weekly 3 times we are doing 3 session weekly, one after 1 day alternate. Second batch we have of the valvular diseases. Third batch we have of the angioplasty. And fourth batch we have of the heart transplant patient have already been here. And after going home for the 6 months and 6 months to 1 year, they continue the exercise using the tele-rehabilitation. So heart transplant patient generally they have all the instrument with them like pulse oximeter, BP instrument, everything they have. So before, during and after again during the rehab session we ask them to take the vitals and we record it and then it is fed in again in the electronic health record.
Thank you very much, ma'am.
Yes, sir.
The data that you had given
Yes.
about the recovery and the improvement outcome
Yeah,
data,
yeah.
was it only for tele-rehab or for both tele-rehab as well as people who have come to your center?
Yeah,
Is there
sir,
a
2 datas I have represented. This one is of the tele-rehabilitation. Fine. And this one is for the center base, which we have not included for the
so the
rehab.
delta is not very different. It's almost similar.
Yeah. And sometimes because the patient in the tele-rehabilitation, what happens, sir? Once they feel good that they are exercising 1 hour a day in the morning, they keep on coming even though their sessions are over. Because we are not changing the link or video conference link, we cannot change it frequently because patients are used to the same link. So what happens, the patient comes on the continue basis and even during and after the rehabilitation, what we do, we ask the patient Once they complete the 3 months of the tele-rehabilitation, to come at our center and we check the 6-minute walk test again. So sometimes we get more improvement in the tele session than the center-based session,
So
because
there can be a study which is done purely on this, and application can be done on the
tele-rehabilitation part itself.
The comparative study of on-site
Tele
versus
and center-based. Yes, yes.
I think
Center-based.
that would be. I mean,
that can be published later on with this.
I mean, this answers your question probably, right? I mean, reaching out to the farthest corner of the state or wherever, right? Yeah. He says more data needs to be for the technology. See, the initial days, his question was more data needs to be generated for this technology shift. Yeah, data, see, those days there was not so much of awareness. So it's something like UPI was, it just started and it's all over there. Simply put, this stores your activity, right? There's something called Google Fit in this. It shows the number of steps that I have done. And the number of steps can be seen by my wife, which decides the size of my dinner. If I don't walk, I don't get 4 roti se 3 roti ban jayega. You know, it's as simple as that. I mean, reward and punishment can come from your wearable devices.
Isaac Paula would be very proud of you, sir.
I have an excuse that I had put it for charging and I had gone for rounds. 25 साल का शादी में झूठ बोलना सीख जाते हैं हम.
Thank you so much.
But a beautiful, I mean.
One last question, ma'am.
Yes, sir.
With your experience, with your data, if you have to rate the tele-rehabilitation from 0 to 10, based on the adherence to the patient, based on the outcome, what would you rate between 0 to 10?
Sir, I would rate like 7 or 8, because once the patient is used to that technology of video conferencing and all, they themselves feel the benefit of the exercise, and it is very easier to perform the exercise at home rather than the coming at center. Whenever the patient come here for the consultation of rehab itself, just for the example, if someone is coming from the Ahmedabad itself, we have to convince that patient that you come here, you will feel the benefit. Once the patient come here 3 times a week, then they'll say that okay, I'll continue. But initially for 2 to 3 days, we have to explain the patient that okay, once you come here, you'll feel the benefit or you'll feel good if you do the exercise over here.
So your educational counseling works ultimately.
Yes. It is the utmost important that you counsel the patient at the first session. The other positive benefit of the tele-rehabilitation is once the patient is used to that, patient will continue by themselves. You don't have to do counseling again and again, because they are feeling improvement in their daily activities, daily steps, or being more positive psychologically also, so they'll continue with that.
And you being a cardiac pulmonary center, you call the patient for follow-up, or patient comes to the cardiologist and then visit your center, or
Sir,
you
both
personally
both the
okay.
ways. Surgeons and doctors, they send the patients to us, but still from our side also, as a physiotherapist, we also guide the patient from the downstairs that there is the center, you once visit there.
No, I'm asking for follow-up. Once the patient is completing 15 sessions of tele-rehab, and after that 15 sessions...
No, whenever the patient comes for the tele-rehabilitation, we inform that whenever you come here after 1 month follow-up, 2 month follow-up, or whenever you come here, you have to visit again at the center.
And they genuinely come
and
to
again and again we remind during the tele-rehab sessions also that whenever your turn is there for coming in the OPD, you please visit, and patient comes at the center.
And how do you inform regarding the tele-rehab session to the patient? Do you...
Whenever they come first for the consultation, that time we have to explain that as you are not staying in the
Ahmedabad, you have decided the days like Monday to Wednesday or Monday, Tuesday?
Yes. Alternate days we have decided, sir. For CABG, Monday, Wednesday and Friday, morning 9:30 batch if we are giving for CABG.
Right.
Then Tuesday, Thursday and Saturday batch, 11 o'clock we have kept. So someone is not managing the time at 9, they can join at the 11. And same for the valvular disease on the alternate days.
Thank you very much, ma'am.
Actually, the beauties of telerehabilitation, I just want to add, the one it starts, for example, 3 or 4 session, and they feel better. Sometimes, yes. So they will insist us, no, I don't want to go for tele. I just want to go to your actual sessions. So it's a beauty, how to make the patient adhere to the rehab. So it's one of these, or sometimes we go for hybrid model. So once a day he comes to our department, and twice maybe he go for telerehabilitation. So we are flexible, and it is a patient centric. If patient has some problem and he doesn't able to come for thrice a week, so we make them for them hybrid model. So it's something like that.
Harda ma'am, can this be extended into transplant patients and
We do in transplant also.
नहीं look, I mean in
Renal
solid
and
yeah
heart transplant, sir. Telerehabilitation is we are doing a heart transplant.
Definitely, sir. I mean, in any way, the patient should be educated, and few patients are very keen that I want to exercise. Few patients are, yes, you have to have a hunter to make them exercise, and few are in between of that. So, and screening is very important. And yes, we have to use a technology at least, and then we should have a data and phone number and access to the patients. In few we can prescribe, in few we have to supervise, in few we have to have a telerehabilitation. That is what a robust criteria should be, that to whom to be given an unsupervised protocol and to whom it should be supervised. Yes, definitely it should be done, because what is happening in the transplant center, the patient are not staying nearby. At least for 3 months they may be staying nearby, but most of the time they are very far away from the center. So there should be something like this to be done.
because we are trying to do that. I mean, we have one of your civil kai student who's with me, Yogi. He was doing it in ILD patients. I think he's done a few ILD patients tele rehab and acha results. I mean, I had my initial, old school thought. Probably I was wrong. End results were good. I mean, okay, we didn't, as I always say, we are clinicians, itna outcome measures sab measure nahi kiye the, but he did it in a few ILD patients, and okay, the quality of life improved.
Fear among us, fear among patients, and fear among clinicians should be washed out.
Old school thoda okay, now
At the 3
you have
places
to
that we have
grow
to
up
go.
with the times. Everything is a learning.
Ma'am, I have a question. Thank you for such an informative session on the new technology. You have talked about the apps that have been developed for mobile apps, right?
Yes.
So is that still on a trial basis, or if it is not there, then which should one that can be used?
For the wearable devices, patches and all?
Yes, ma'am.
See, wearable devices now in the market, you have the patches which will cost around 5,000 to 6,000 itself. But we need to check the reliability and validity. They around 90 to 93% they'll give you the accurate ECG and all. So those patches will cost around 5,000 itself for one patient, and that will give you all the data in your phone itself. So those kind of wearable devices you can use for the private practice or at your center. But again, you have to choose the patient. For it is easier to do the exercises with the low risk and the moderate risk than with the high risk patient. For the high risk patient, it is advisable to do or perform the exercise when you are in the one set of hospital. So any emergencies happen, you can deal with that. And for the low risk patient, you can use that devices, wearable patch and all, which are now easily available in the Ahmedabad market itself. So that will give you the data on the phone itself.
Okay, thank you.
Yes, please.
Thank you, ma'am, for your valuable information.
Yes.
Ma'am, my question was, any data has been recorded for ejection fraction change, like how much percentage of change can be expected in how much duration?
No, that was not done that way, but we have the heart failure patient. One video you might be seeing before when we were waiting. That patient name is Nayanbai. So generally the patient come here for the OPD visit. They have all the records like ECG, echo, what medications they are taking and all. So from the echo report, you will come to know how much the improvement in the EF. That we are noting down in our software, which is HMIS. So we'll come to know, okay, this patient has undergone 2 months of exercise and we got the improvement of the 5% in EF, like it was improved from the 15 to 20. So patient feels happy like that. So duration of exercise and the EF, right now we are on the way of collecting the data, but we are feeding it in our software. Over the time, when we have more number of the heart failure patient in the OPD, we can correlate more easily. Now the number of patients are less to say that the 1 month of exercise will improve this much of ejection fraction, because many factors are there, type of the heart failure, medications patient or patient age, other risk factors, this all affects the ejection fraction as well as the exercise response. So we have few patients data which will say that the okay, ejection fraction was not improved or it was improved, but the duration, with the duration of exercise, it is not correlated yet.
Means we can, like in how many months we can ask for the follow-up for the echo, like generally 2-3 months?
Generally 3 months.
Okay.
3 months.
And the data here of the pre-test 6-minute walk test was taken.
Yes.
That was taken on which date, means after post-op? Like which
Whenever
day?
the patient joins the rehab, first day of that we are taking the 6 minute. We get the patient of your post-operative 20 days to 1 month to 2 months. Whenever patient comes to us, we enroll, patient is ready, we enroll in the rehab. So that is of the mixed duration from 1 to 2 months, you can say.
Okay, so phase 2 cardiac rehab.
Phase 2 cardiac rehab,
mostly the
right now we are.
patients are.
Yes, yes.
Okay.
We take during the discharge also, but that we are not considering for pre, because the acute effects of surgery and bed rest is there. So we are not considering that for the pre-rehab. We are taking the data of at the rehabilitation center itself.
And this data of the 3 months like duration intervention post
yes,
taken?
Yes, yes.
Okay. Thank you, ma'am.
Thank you so much.
Good afternoon, ma'am. No,
Yes.
it was very informative session. I have just one question, that whatever that if I am wearing that device and that application is installed in my phone,
yes,
so that all my data is included in their server, right? So
Yeah.
is there any clause of data privacy is there, or it could be shared with other healthcare providers?
No, it will,
companies like
the Frontier system, they'll not have your data. They'll mail the data to you. Like whatever we are asking, data we are getting, that we are getting on our mail ID. They might be having them some confidentiality clause and all, but I think they are not having the data what we are getting from our patient, that we are having with us only. Frontier
so app
device
is
will
not
not get,
installed,
they'll not
yeah,
get the access to our data.
Okay.
That will be us with us.
Thank you so much. We would like to request Dr. Chintan Jain, Senior
One
Cardiac
question is there from him.
First of all, thank you so much
Yes.
for such an amazing presentation, ma'am.
Yeah.
From my side, many of patient is from the outskirt area.
Yeah.
So they were not coming from the continuous follow-up.
Oh, fine.
So I am doing the teleria for the many patient, and they are not coming at the KD or the any respected hospital. But
Yeah.
for at that patient, what we side done from our side for the outcome measurement. तो हम क्या कर सकते हैं, आउटकम मेजरमेंट हम कैसे ले सकते हैं ऑनलाइन?
What kind of outcome measure you take for your patients generally, so I can guide?
जैसे बेसिकली 6 मिनट वॉक टेस्ट है, तो अभी पेशेंट हॉस्पिटल नहीं आ सकता है,
हाँ.
तो हम उसके लिए क्या कर सकते हैं? जैसे कि मेजरमेंट हम एरिया मेजरमेंट नहीं कर पाएंगे वहाँ पे पेशेंट के साथ, तो हम जजमेंट कैसे ले पाएंगे, मतलब पेशेंट को इतना इम्प्रूवमेंट हो रहा है या नहीं?
So generally you can go for any of the tests which patient can do at this home itself. You can go for the step test, you can go for chair sit to stand stat. test, any test which utilizes the less space and patient can understand easily, as well as you have to see that it will not harm the patient more. Like 6 minutes step test and all are the submaximal test, sit to stand test and all, so that you can utilize it. I think there are only few studies which says that the how 6-minute walk test you can take at the patient home or at the patient side, that you can refer it few studies. Or my suggestion is you go for the step test itself, so patient can hold the railing and do up down whatever times in the 1 to 2 minutes, and then pre and post vitals response you have to teach the patient how to take by themselves. So and RPE is the most important thing. We are taking it for the all the telerehabilitation patient. After finishing the session, we ask the we show the chart to the patient online, and we ask the patient to rate the rate of perceived exertion. So that also you can have it.
Okay. And I'm just too new for the टेलीरिहैब, तो कौन-कौन से complication and the क्या चीज़ है तो हमको टेलीरिहैब में थोड़ा ध्यान रखना चाहिए.
Telerehab, if you are going for the cardiac diseases, risk stratification is must. See what all medication patient is taking, how much is the patient initial exercise capacity is there, that all the things you have to check it. And initially when patient is enrolled, it is easier that you go for the low intensity exercise. After 12 to 15 session, you increase the intensity little bit to moderate. Till then you go with the low intensity, so you also get the response of the patient.
You can utilize the patient space only, sir. You can ask the patient from one room or from one distance or one corridor to another area. If he is getting 5 counts or 5 repetitions, so you can ask the patient. Initially, when you start, obviously pre and post measurement of vitals you need to teach to the patient, and you can ask the patient on first day if you are covering your corridor 2 or 5 repetitions. Gradually after 15 days how many distance you are covering, how many repetitions you are covering, you can ask the patient for that only. There is no need to go for 6 minute or kind of walk distance. You can just directly ask the patient to count the distance.
Excuse me sir, I think we can discuss
please.
We are
please sir, please.
Yeah.
Thank you sir.
Thank you so much sir, and thank you ma'am.
Thank you so much. We would like to request Dr. Chintan Jain, Senior Cardiac Physiotherapist, to felicitate Dr. Aisha Mullah ma'am. Thank you. We would like to request Dr. Vaibhav Joshi sir, Senior Cardiac Physiotherapist, to felicitate Dr. Sudarshan Nambi sir. Thank you so much. We would like to request Dr. Ganesh Makwana sir, Senior Cardiac Physiotherapist, to felicitate Dr. Anjum Akhtar sir.
Thank you so much. Now we'll proceed further. We would like to request, you can have a seat sir. Now we would request to welcome Dr. Mihir Mehta sir to deliver vote of thanks on behalf of UN Mehta Institute. Meanwhile proceeding, we would also request you all to fill the feedback form by scanning the QR code which are available.
It was a wonderful session. Thank you dignitaries to coming here and panelists to come here. Also I thanks all the participants who are coming here with and giving their valuable time for this symposium to be a successful. I would also like to thank Dr. Nehal Shah sir, so to be the whole session he stays, he really liked I think cardiac rehabilitation, so probably he is for younger generation, for our he is a very inspiring person. I would also like to thank my colleagues, Dr. Aisha ma'am, Dr. Falak, and all the physiotherapist, senior physiotherapist team to make this program very successful. Also like to thank all my students, MPTs, ACPs, lecturers, all. Really thank you for this program. I would also like to thank our director sir, IT department, Hiren bhai. He was all, કાલ રાતથી બધા એમની પાછળ પડ્યા છે. ફોટોગ્રાફી ડિપાર્ટમેન્ટ કન્ટિન્યુઅસલી અમારી સાથે જ હોય છે. પ્રોબેબલી આપણે તો હવે ભાઈબંધ જેવા થઈ ગયા કે દર મહિને અમારે કંઈક ને કંઈક એમની જોડે ચાલતું હોય છે. I would also like to thank all the ancillary department, utility department, all the department of UN Mehta Institute to help us to achieving this symposium to be a successful. Once again, thank you all, and I will end the session. Please, we have arranged some high tea and the snacks. Please go on and have your snacks. Thank you.
So on behalf of UN Mehta Institute of Cardiology and Research Center, we extend our heartfelt gratitude to all of you for gracing today's event with your presence. Thank you, everyone. As Sir said, there is an arrangement of high tea and snacks in the exhibition hall which is present behind the auditorium, so please join us for it. And here is the feedback QR code, so please scan it and fill the valuable feedback from your side. Thank you so much, everyone.